Sorry. Good morning. Today I'll be taking up a topic, medicine one, that is a very important topic, neurology. And in this topic, we need to take down some notes, good notes for discussion, as well as we need to understand the topic. Okay. We start with the very first topic for today, that is seizure disorder. Seizure disorder. First, the definition of this term seizure. What do we mean by seizure? Seizure is defined as a paroxysmal event due to hypersynchronous central nervous system discharges. So, if we divide the term paroxysmal means sudden, hyper means more, synchronous means together. Paroxysmal means sudden, hyper means more, synchronous means together from the central nervous system. If you remember the word central nervous system, it is made up, or nervous system is made up of a central and a peripheral nervous system. Like we have the brain, we have the spinal cord, that is a central nervous system. From there we have the nerves which form the peripheral nervous system. We recall that the term seizure arises from the central nervous system, from the very big boss, that is the cortex. So we should be very clear in our concept that the seizure arises from the word cortex. Cortex, part of the central nervous system, not from spinal cord, doesn't arise from the subcortical structure. Now, which cell layer in the cortex gives rise to the seizure? This has been a very famous one-liner. A pyramidal cell layer. There is a motor or a pyramidal cell layer that we have in the cortex that gives rise to a protocol of seizure. Okay. Now, another term that we already know is the word epilepsy. Epilepsy. Epilepsy has been well defined as two or more than two unprovoked seizure over a duration of 24 hours. Now the word is unprovoked. We don't have any provoking factor for this kind of a story. Like we have got hypoglycemia, you might have seizure. You got hyponatremia, you might have got seizure. Something like this is always provoking. This is an unprovoked event that creates a seizure. Two or more than two over a 1 day duration is defined as epilepsy. So we have solved one line of questions. One is this pyramidal cell layer. Other one is this dash number of seizure is defined as epilepsy 24682. Now, how do we classify seizure? The classification of seizure disorder is on a very basic funda. It all arises from the cortex. In the cortex, there can be a neuron like this. Discrete lesion, or could be a diffuse lesion. There are two sets of lesion in the brain, discrete lesion and a diffuse lesion. Yeah, almost for the pediatric patient also the same. Jabalpur lasts for more than 15 minutes. Leave it there. Jabalpur, I'll come to that definition later. What are you asking for? Discrete lesion and diffuse lesion. There are two kinds of lesion that we get in the brain. In a discrete lesion, there is a potential that it will send a signal to only one body part, while a diffuse lesion has got a potential to send a signal for every body part. Discrete lesion will send a signal for only one body part. Diffuse lesion will send a signal for every body part. This is a focal onset, focal behavior known as a focal seizure. This is generalized onset, diffuse behavior known as a generalized seizure. So we got two kinds of seizure, focal and generalized. Now the erstwhile name that you know regarding the word focal is the word partial. The word partial is no more, it has been replaced by the word focal recently. Around 3 years back in Harrison, as well as all the journals, articles everywhere, they replaced the word partial with the word focal. Now diffuse region, generalized seizure. What do we understand by this? Now generalized seizure will be caused due to certain reasons in the brain, like toxins, like drugs, like metabolic event. Toxin, drugs and metabolic event in the brain can create a generalized seizure. I'll give you one reference for this. If someone asks you in a patient with hypoglycemia, which kind of seizure do you imagine? Generalized seizure. In a patient with alcohol withdrawal, generalized seizure. Now focal, someone will ask you like this, a patient with brain tumor, neurocystic psychosis will have which kind of seizure? Focal seizure. So this is the one way of understanding it, the focal and generalized. Now how do we classify focal seizure? Focal seizure is all classified on this parameter. LOC. Loss of consciousness for us in the case sheet, but the word C means a lot. It means consciousness, it means contact, and it means cognition. So these are the three terms that we understand from the word C: consciousness, contact and cognition. This is the meaning of the word C. Sometimes a patient is having a focal seizure, he or she is communicating with the other person like, I'm having a focal seizure, look at me, what is happening? And sometimes they are not communicating. So the word C is also communicating. So they have a contact with the environment, they understand what is going around, cognition, and they are conscious enough, consciousness. So the word C means a lot. If there is a problem in cognition, it is known as a dyscognitive seizure. If there is no problem in cognition, it is known as a non-dyscognitive seizure. Dyscognitive and non-dyscognitive seizure. Purana naam, the old name that we know, is a complex and simple. Dys means dysfunction in cognition, non-dyscognitive means non-dysfunction in cognition. The old name that we know is a complex and simple. Complex partial seizure, simple partial seizure. Those terms have been replaced recently in Harrison by the word dyscognitive and non-dyscognitive. So this is one type of classification. This is the second type of classification of focal. And the third variety is this. Sometimes if there is a discrete lesion in the brain, it will send a signal. Discrete lesion will send a signal, will excite only one body part, yes, but around that discrete lesion there is cerebral edema. Because of that, seizure will occur in other body parts. So initially it is focal and then it becomes generalized. So the third variety of seizure that we know is with secondary generalization. So this is one type of seizure, dyscognitive, non-dyscognitive, and the third variety is with secondary generalization. Now in a life of focal seizure, we get this kind of a problem also, known as Tort's palsy. The word palsy in Greek means paralysis. There was a patient who was having a focal seizure. In the body part where the focal seizure occurred, that body part after the seizure went off, did not move. So we had a patient of this kind of a story, post-ictal paralysis. Paralysis is weakness, ictal is seizure. After the seizure, the body part that was moving a lot did not move at all. That is after the seizure paralysis, Tort's palsy. One thing, nothing much to worry about it. It is usually self-recoverable. It is usually self-recoverable. Like a patient of stroke will live with the problem for a very long time. This patient will recover most of the time. It is self-recoverable kind of an event. Another story, in a life of focal seizure, sometimes we may see a seizure in the lower limb. It might start in the finger, the toes, move to the foot, move to the leg, might start in the leg, move to the toes, like this. So it is a possibility that a focal seizure will arise in one body part, will start distally, move proximally, or might start proximally, move distally, one part to the other part, this way, this way. This kind of a story in a focal seizure is known as Jacksonian march. So we had a patient with focal seizure whose seizure tendency in a body part was distal to proximal or proximal to distal, that is known as Jacksonian march. This season we got one simple question. Todd's palsy occur in which seizure? Generalized or focal? It occurs in focal seizure. Jacksonian march occur in which seizure? Generalized or focal? It often occurs in a focal seizure. So we should know that Todd's palsy and Jacksonian march are two things which occur in a focal seizure. Now I'll put down a question interesting at this point. Write it down. You have just admitted a young male. You have just admitted a young male with history of seizure disorder over left half of the body. There is no history of loss of consciousness, LOC. He is brought 2 hours after the symptom onset. Currently, he is awake, conscious and oriented. Power in the left upper limb is 0/5, where he had the seizure. Rest central nervous system examination is within normal limit, WNL. You got an NCCT of brain done for the patient, which is again within normal limit. Now the question is, best course of action at this time. Best course of action at this time. Cerebral angiogram, lumbar puncture, MR angiogram, psychiatric evaluation, reassess in few hours. Tell me our answer for this one. A patient, young male, has come to you with a history of focal seizure over left half of the body. You found his limb did not move after the seizure. You got paranoid, you thought it's a case of stroke. You got a CT scan that was absolutely normal. Best course of action at this time would have been, okay, fine, good, good. Rhythm correct, I believe. Everyone knows this fact that the patient had Todd's palsy. Best thing is to wait and watch. Why? Because most of the time this kind of a story is self-recoverable. It will recover over a period of time. So just wait and watch. Things like MR angiogram, cerebral angiogram will come into the picture quite later. Something which you need to be bothered as a physician is psychiatric evaluation, I believe. Very often we see in our clinical practice patients with pseudo seizure more often than a seizure disorder. What you can get done is an EEG, electroencephalogram, to rule out a seizure, yes. But one blood test that you should know as a one-liner question again, write it down, serum prolactin. There has been a study that raises a clear concept that serum prolactin rises 30 minutes after a true seizure. So someone had a true seizure, after half an hour we checked the serum prolactin, it was actually found to be high. So serum prolactin is a blood test that you can really make it out very clear is the patient having seizure or pseudo seizure. Okay. So let's proceed. Now we'll see the generalized seizure type. One of them very interesting, absence seizure. It was a patient who was actually physically present but mentally absent. We had a patient who was suddenly lost and was staring at us. So he was physically present, mentally absent. We understand that this patient has a loss of contact with the environment, LOC, and he was not falling here and there. The tone of the body was very well perfectly normal. So we had a patient with loss of contact with the environment with tone of the body being perfectly normal. This loss of contact with the environment is all of a sudden, is abrupt onset, and is of a usually duration of less than 30 seconds. So we had a patient who has had a stare kind of a look for less than 30 seconds. All of a sudden, that was a patient with absence seizure, generalized seizure, absence seizure. In the patient's life, usually they had not a full body movement, they had a subtle motor sign. There was a minor motor movement that was seen or subtle motor signs experienced by the patient. With all the things said and done, after the seizure subsided, there was no post-ictal confusion. Patient was well conscious oriented, then there was no post-ictal confusion. And the age group where it starts at most likely is 4 to 8 years of age. They found in epidemiological studies that absence seizure usually starts at an age of 4 to 8 years very often. And by the God's grace, it gets alright, that is spontaneous remission. In around 60 to 70% of the patients by 18 years of age. By 18 years of age, the patient gets alright in most of the cases. So it has a spontaneous remission value also. How do we diagnose an absence seizure? By doing an EEG, electroencephalogram. In EEG, we get a very typical pattern that is known as bilateral 2 to 4 Hz spike and wave, which is often PPT, precipitated by a maneuver which is known as hyperventilation. So bilateral 2 to 4 Hz spike and wave, which is often precipitated by hyperventilation, is something very perfectly seen on an EEG in a patient with absence seizure. If we all imagine, how does a spike and a wave look like? A spike is like this and a wave would look like this. Sometimes the wave also looks like this. If you see, this is the wave and this is the dome of some monument, some mosque. This is also known as spike and dome pattern. So this was an old one-liner question that we have faced in the one-liner pattern. That spike and dome pattern is suggestive of which kind of seizure? It is suggestive of absence seizure. Okay, and it is often precipitated on a maneuver. Make the patient breathe rapidly, hyperventilation. A good clinical history which you recall from pediatrician, that the teacher tells to the parents that your child is often not paying attention in my class, often getting distracted, and the top most problematic thing is that he is staring at me, and when the teacher goes near him, he is blinking at her, he is moving his lips, minor motor movement, subtle motor signs are seen, and after the seizure subsides, he is totally normal, no post-ictal confusion. So that's a very excellent story that we get of a term known as absence seizure. Now, another kind of seizure that we need to be aware of, generalized of course, is myoclonic. Myoclonic are also known as a jerky movement. So many of us, like we're just about to sleep somewhere and someone touches us suddenly and we just get up like a jerk. We get up like a jerk, that is a myoclonus. Myoclonus is something physiological that can occur at the onset of the sleep, but it can be a problem, seizure, when something goes wrong in the brain. So it is known as also known as myoclonic seizure. Jerky movements, unilateral or bilateral. Myoclonus can occur in the brain due to hypoxia, due to degeneration, due to metabolic. Hypoxia, degeneration and metabolic event in the brain produces a myoclonic seizure. I'll give you one reference for this. If someone asks you one simple question, in a patient with hanging, which kind of seizure do you predict? Most likely a myoclonic. Why? Hanging, hypoxic injury in the brain will precipitate a myoclonus. Degenerative disorders we'll learn later in the day, prion disorders, they also have a myoclonic event. Metabolic can be 100 causes. Okay, so we should know that the myoclonic seizure arises basically because of 3 events in the brain like this. Now we'll consider the discussion on a very important topic that we know, juvenile myoclonic epilepsy. Juvenile myoclonic epilepsy, well abbreviated as JME. Juvenile myoclonic epilepsy, well abbreviated as JME. The word juvenile was often given to it because it was seen in the juvenile age group, that is early adolescence. So we had patients who had seizure disorder in the early adolescence, early teenage. They fell into the group of most likely juvenile myoclonic epilepsy. One more thing, usually these patients don't have an identifiable cause. In the brain there is no hypoxia, there is no degeneration, there is no metabolic problem, but the word still remains myoclonic. It is still of an unknown cause. In these patients, family history is often seen to be positive. This season we got one simple question, which chromosome is responsible for the genesis of this problem? Chromosome number 6. Apart from this, these patients often exhibit bilateral myoclonic jerks, which are often seen on getting up early in the morning, that is awakening, often PPT, precipitated by fatigue and by alcohol. With the myoclonic jerk that often happen, they have no loss of contact with the environment. They are well conscious oriented people, LOC is absent. And in the patient very often, one term that they use in Harrison very often, automatism. Automatism is lacking. What is this automatism? It looks like someone automatically, someone faints on the road, he never gets up like a robot and he starts walking. He or she rubs his eye, blinks his eye. All those movements that happen, which are known as subtle motor signs, also known as automatism. So these kinds of movement that we see in the patient are automatic movement, subtle motor sign, they are lacking in the patient. So automatism is not seen in the patient, in a patient with juvenile myoclonic epilepsy. Okay, subtle motor signs are not seen. One more thing, if you don't well treat them on time, majority of these patients will develop this generalized tonic-clonic seizure. They may throw up a full-blown convulsion, which is known as GTCS, and 1/3 of these patients can also have absence seizure. So we may have a patient with a stare look 1/3 of the times, we may most of the time have a patient sometimes GTCS. But the moral of the story, that the most common manifestation or presentation is always a myoclonic jerk or myoclonic seizure. So most of the patients with JME present with this myoclonic jerk. But the story is this, if they are not treated well on time, they may land up into GTCS and absence seizure. Okay. So that's a very simple topic, juvenile myoclonic epilepsy. Another thing, mesial temporal lobe epilepsy. We know that fact that there is a seizure disorder which is known as temporal lobe epilepsy or mesial temporal lobe epilepsy. In these patients we get a focal seizure with LOC very often, known as a dyscognitive seizure. A focal dyscognitive seizure type is seen in this patient, temporal lobe epilepsy. And in these patients we have got a different thing, a very common thing that we see, that is known as deja vu. Deja vu basically means familiarity with unfamiliar surroundings. Familiarity with unfamiliar surrounding is known by the term deja vu. On an imaging, in these patients, we got an enlarged temporal horn and on imaging we may also have a hippocampal sclerosis. Treatment, simple, remove the cause, that will be better. Go ahead and do a temporal lobectomy. Remove the temporal lobe, temporal lobectomy, or remove the hippocampus with amygdalo-hippocampectomy. So temporal lobe lobectomy and amygdalo-hippocampectomy are the two surgical procedures that are undertaken for the primary treatment of temporal lobe epilepsy. So we should understand that the treatment of choice for temporal lobe epilepsy is temporal lobectomy. One thing we realize, in these patients, anti-epileptic drug AED, they are not very amenable. They are often resistant to anti-epileptic therapy R. So these patients we found were more preferably happy with the surgery, less happy with the medical treatment. So they are more amenable to surgery, refractory to medical line of treatment. Okay. Now we will consider the discussion on this, how to choose a drug for any epileptic patient or a patient with seizure disorder. We decide on the drug as drug of choice, DOC. A very simple funda that you realize in clinical practice, you will see it, that there are around 20 to 40 anti-epileptic drugs. All of them are very good, but you don't give a drug for 1 or 2 days. You give it for minimum 2 years, taper it down, another year, 3 years, you stop it down. Sometimes even lifelong therapy is required. So we have to take a drug out of all the anti-epileptic drug which is good in action and less on reaction. That means a side effect. All the anti-epileptics that we know, most of them have got 1 or 2 very bad side effects. So we realize that a drug should be decided on the effect and a lesser side effect probability. So drug of choice should be the one, good effect and a lesser side effect. We start with the very first one, focal or the partial seizure. Any ideas from your side? Do you know any drug of choice for this? Drug of choice for focal? Lorazepam. See, I think so you misread this topic in pharma. I think so you totally misread this topic in pharmacology somewhere in the guide at least. Because the pharma people for the last 20 years are telling one thing, carbazepine is drug of choice for focal or partial seizure. But realize this fact, Carbazepine is a very good drug for me, but it's a very bad drug for the patient. On a long-term therapy, we often find patients on carbazepine therapy developing aplastic anemia and hyponatremia. So around 5 years back, we had someone new, oxcarbazepine, but the side effect profile almost remained the same. It was not very totally safe kind of a drug. Remember phenytoin? Phenytoin is again a very problem drug. Nowadays, we've got one good anti-epileptic drug, that is lamotrigine. Lamotrigine has got one side effect. Lamotrigine is one anti-epileptic which came into the market 5-6 years back. It has got one side effect, Stevens-Johnson syndrome. But the incidence of Stevens-Johnson with the use of lamotrigine is just a percentage. So don't worry, we have one faithful anti-epileptic nowadays which has got a good effect and a lesser side effect. So write it down in a form of a good mnemonic. Partial or focal seizure. A mnemonic, Lokpal. Annazare is forgotten will, Lokpal will. L stands for lamotrigine. O stands for oxcarbazepine. C stands for carbazepine. P stands for phenytoin. And L stands for levetiracetam. And I saw some people answering me the last one, levetiracetam, as drug of choice. Read Harrison 18th edition, go back and read it, don't play your own mind there. These first four in Harrison are clearly mentioned at the first line anti-epileptic drugs, and I am a neurologist, I follow this protocol. I never give levetiracetam as a focal therapy drug of choice. Levetiracetam is very often an add-on drug. So lamotrigine is the most preferred drug nowadays because of a lesser side effect and a good effect as compared to the rest of the three. So you can remember this mnemonic very well. Levetiracetam is often an add-on drug for focal seizure. Till date, there are not very good trials that could substantiate that this is a good drug for monotherapy basis for controlling focal. So for focal and partial seizure, levetiracetam is something wrongly told as drug of choice. No, it is often lamotrigine nowadays. If you remember something from our pharma section, side effects, lamotrigine, one common side effect that we had, not very common, we should know the name, Stevens-Johnson syndrome. Carbazepine, hyponatremia and aplastic anemia. Phenytoin. Phenytoin is something which is known side effect with a big H with it. If you remember the 6H phenytoin side effect, hypersensitivity, hyperglycemia, hyperplasia of gums, Hydantoin syndrome, hirsutism, hepatitis. So these are the 6H side effect therapy that we know with respect to phenytoin use, plus in anemia, that is megaloblastic or macrocytic anemia. Macrocytic anemia this time occurs due to folic acid deficiency, with a bone disorder also osteomalacia. So that's why when you write phenytoin in a prescription paper, you always give a folic acid, you always give a calcium to the patient. Otherwise patient might go into macrocytic megaloblastic anemia or maybe some bone disorder. Write down a question on this. A 72-year-old male with history of focal seizure. KFT, kidney function test that we did for the patient is within normal limit. Best drug to manage the patient. Option A, valproate. Option B, oxcarbazepine. Option C, levetiracetam. And option D, pregabalin. Tell me a quick answer on this. A 72-year-old male with a normal renal function with a new onset focal seizure, what should be the most preferred drug that you need to give for the patient? I think so, rhythm correct for everyone except for I believe in the Meerut center, which the answer is levetiracetam. Just revise the mnemonic, Lokpal. So if they remove lamotrigine from the list, I think so the next best drug that I have in the market is oxcarbazepine for such a patient. Levetiracetam is often an add-on drug for management of focal seizure. He is not asking you the add-on drug, he is simply asking you what is the most preferred drug in such a setting. I will go with oxcarbazepine. Okay. So go by the mnemonic, play safe. Write one more question from the national board which has been wrongly given in the guide. Write it down. Long established anti-epileptic drug. Long established anti-epileptic drug used in focal seizure are all except option A, valproate. Option B, carbazepine. Option C, lamotrigine. And option D, phenytoin. Long established anti-epileptic drug used in focal seizure are all except in the Lokpal bill there was no villain, there is no valproate. Okay, simple funda. Unfortunately, I read your guide, national board guide. He has mentioned the answer as lamotrigine. Wrong answer. Okay, the answer is valproate. For one reason, valproate is not used for focal seizure. They are not very good drug for focal. Okay. Now we'll proceed and we'll see another seizure type that we know, that is generalized tonic-clonic seizure and juvenile myoclonic epilepsy, JME. For this, drug of choice very simple, V for valproate, V for victory. Number 2 in the list, lamotrigine, and number 3, topiramate. Okay, so VLT is a very good mnemonic that you can remember at this point for GTCS and juvenile myoclonic epilepsy. V for victory, V for valproate. So if someone asks me drug of choice for GTCS and JME, it's very simple, valproate. Now the problem lies on this very topic. I am very sure there is a lot of discrepancy in the guide and the textbook about this absence seizure. Chalo, any schools of thought from your side? Drug of choice for absence seizure? Ethosuximide or valproate? Two answers only. I'm very sure there is always a 50-50 on this anytime. Unfortunately, written in the one of the famous pharma guide is valproate is drug of choice. Okay, wrong answer. If you read Nelson Pediatrics, all the higher book of neurology and all the journals of neurology, they clearly mention one word. For absence seizure, drug of choice is ethosuximide. Okay, not valproate. Ethosuximide is not available in India. Remember one way. Ethosuximide is not available in India, and that's why in India population we prefer using valproate. So if someone puts me 1-2 questions on this, drug of choice for absence seizure, I'll mark ethosuximide. In India, if they give me, I'll mark it as valproate because ethosuximide is not available in India. Last in the list is lamotrigine. Just to add to your knowledge, lamotrigine, EVL. So this is the order of preference. If ethosuximide not available, you go with valproate. If still not valproate a problem, then you can go with lamotrigine. Now, actually, I read somewhere in the pharma guide that less than 3 years is etho, above 3 years is valpro. Something to comment on this point. Absence seizure start at an age of 4 years. How can you give the drug at 3 years when it starts at 4 years? Something that practically fails on discussion. So someone asked me a very simple question, drug of choice absence, I'll always mark ethosuximide. If they give me an option for India, I'll go with valproate. If they remove etho and valpro, that happened in this exam on the computer version, on the computer based exam, there was no etho, there was no valpro, we went with lamotrigine. Now, thing for discussion, a very important thing, what to do about pregnancy. In pregnancy, there are 2-3 things that you need to remember. One easy MCQ of my era, least teratogenic anti-epileptic drug. Least teratogenic anti-epileptic drug. Answer is phenobarbital. Now another question, safest anti-epileptic drug. Tell me an answer for this one. Least teratogenic is phenobarb. Now what is the safest anti-epileptic drug? I believe that phenobarb, no. Phenobarb is not the safest. For one reason, phenobarb doesn't cause teratogeny, I agree with that, but it's a barbiturate. It crosses the placental barrier sometimes and can cause sedation inside the fetus. So when the child was born on a female who was already taking phenobarb on an anti-epileptic therapy during pregnancy, the child wasn't crying, the child wasn't respiring well. So we had a lot of problem with the Apgar score very often. So as a physician perspective, we need to decide on an anti-epileptic drug which is not very teratogenic, number one. Number two, it is not sedative at all in the regard to phenobarb. So we got an answer around 3 years back. We had one drug, carbazepine. Okay. Carbazepine not too teratogenic and not of course sedative. Please answer me this one. Drug of choice in pregnancy. Any ideas from your pocket? Carbazepine or phenobarb? Chalo, I'll explain this. Neither carbazepine, neither phenobarb is drug of choice. Something wrongly read again in the pharma guide. Drug of choice as per seizure type, write it down. Drug of choice as per seizure type, number one. Only one drug monotherapy. And the third thing that we know is lowest effective dose. So as per seizure type, the drug that is available, only one drug monotherapy, and third is the lowest effective dose that need to be understood. We'll understand this way. If you imagine in patients with GTCS and juvenile myoclonic epilepsy, V for victory, V for valproate, but unfortunately V for villain. During pregnancy, valproate has a tendency to cause this neural tube defect, NTD. Neural tube defect can occur also in the normal pregnancy that we know. In normal pregnancy, it can occur at a rate of 1 to 2%. That's why every pregnant female is given a folic acid supplement preconceptional. With the use of anti-epileptic drug that we know, it jumps to somewhere 10 to 20%. Moral of the story, 100 pregnant female on valproate, only 20 of them have got a neural tube defect, rest of the 80 all is well. So drug that you consider to be teratogenic is not 100%. We need to be careful about the lowest effective dose. Okay, only one drug preferably as per the seizure type that is decided. Write this down also in bold. Do not change treatment during pregnancy. A very important statement. Do not change treatment during pregnancy. They have found in clinical practice that a female who was on phenobarb, was on carbazepine, or maybe on valproate, maybe on phenytoin, became pregnant. During pregnancy, if she consults you, tell her one thing, not change her to carbazepine, don't change her to phenobarb, because changeover sometimes can create a seizure, a breakthrough seizure. So be careful, maintain the therapy that she is already on if she got pregnant on an anti-epileptic drug at the lowest effective dose. Lowest effective dose you can decide by getting the serum levels done. So commercially available thing with us every time, serum levels can tell me and guide me, is the drug in the therapeutic or is in the toxic range. If it is in the toxic range, reduce it to the therapeutic range, and please do not change the treatment during pregnancy. Okay, changeover can produce a seizure. Chalo, I'll give you one interesting question from AIMS, of course, this season. Write it down. A 29-year-old female, 4 months pregnant, first pregnancy, primary gravida, with a history of juvenile myoclonic epilepsy. She is regularly taking valproate. Now seeks an opinion. Okay, what would you suggest her? Immediately taper valproate, start lamotrigine. Option B, switch to carbazepine. Option C, continue valproate with monitoring of drug levels. Terminate pregnancy. A 4-month pregnant primary gravida with a history of juvenile myoclonic epilepsy on valproate comes to you for opinion. What do you tell her? Okay, good, rhythm correct. I believe you understood my point. Do not change treatment during pregnancy. Someone had marked as this, switch to carbazepine. See, half knowledge is always dangerous. You learned this way, safest anti-epileptic carbazepine changeover? No, changing over therapy can become a big problem. Around 10 years back, I'll guarantee on this, around 10 years back, if someone had asked this question, the answer was D, terminate pregnancy. Why? A gynecologist gives an opinion like this, that anti-epileptic that you're giving during pregnant state is something which is teratogenic. It's not 100%, we know this fact. We have to maintain at the lowest effective dose, all is well. But something which gynecologists kept on telling to the patient around 10 years back, not now, that during pregnancy the seizure frequency will increase. No, not a very correct statement. I'll tell you this one. During seizure frequency, during pregnancy, in around 50% of the patients, it is often unchanged. In 20% of the patients, ironically, it comes down, and around 30% of the patient, it often is found to rise up. So we understand from this that around in 70% of the patients during pregnancy, all is well, there is no jump in the seizure frequency, only 20% of them will have a big problem. Don't worry for them 30%, not a very majority kind of a story. Now just to remind us this one more thing, in patients with juvenile myoclonic epilepsy, two anti-epileptics that should not be used as per the pharma book is carbazepine and phenytoin. They found that carbazepine and phenytoin during use in juvenile myoclonic epilepsy patient was increasing the myoclonus. So in patients with JME, carbazepine and phenytoin should not be used. Now the problem is that nowadays the patient is more asking you some questions before pregnancy, prepartum. So in patients with juvenile myoclonic epilepsy, again we found that there was one anti-epileptic drug that could be changed over from valproate. The problem was that valproate is not 100% teratogenic. Yes, it was 20% teratogenic at the lowest effective dose. But if chance occurs in pregnancy, the dose requirement increases and neural tube defect happens, then it is an irreversible damage. So it was a consensus document a year or two ago that if you want to change a anti-epileptic drug in patients with juvenile myoclonic epilepsy, change it prior to pregnancy, prepartum. Change it from valproate to levetiracetam. We have an anti-epileptic newer one which has been worked on for the last 3 years, levetiracetam. So if you want to change from valproate, change it to levetiracetam, but change it prior to pregnancy, not during pregnancy. Okay. Write this question down to understand this concept. Which of the following drug is effective as monotherapy replacement for valproate in a female of childbearing age for treatment of juvenile myoclonic epilepsy? We'll have the option A, levetiracetam. We have the option B, loxamide, lacosamide. We have the option C, phenytoin. We have the option D, carbazepine. A quick answer, easy answer on this. Which of the following drug is effective as monotherapy replacement for valproate in a childbearing age group in a female with JVM? You understood my point, you need to change it over prior to pregnancy, not during pregnancy. If you want to change it over, you put it on levetiracetam. Okay. Now the last line in the coffin of seizure disorder is this: status epilepticus. We have a patient with seizure. After the patient seizure happens, patient becomes unconscious, LOC, again throws up a seizure. So we found that patient who had a seizure for a duration of more than 5 minutes, that was status epilepticus, that is a convulsive phase that the patient was having for more than 5 minutes was a patient with status epilepticus. Sometimes between the two seizure, interictal LOC, between the two seizure, interictal LOC, loss of consciousness. If it was more than 30 minutes, that was a status epilepticus patient. So status epilepticus have got two kinds of definition. One involves a seizure duration more than 5 minutes, and second involves between the two seizure interictal LOC more than 30 minutes, that is status epilepticus. Now the old edition of Harrison, if you read, it mentions that the seizure duration is more than 30 minutes. No, wrong answer. Correct answer, 5 minutes. Somewhere over the years we realized in 30 minutes either the patient will survive or the seizure will survive. So Harrison has given us a gyan recently that more than 5 minutes is more practical a definition. So there is a quick controversy on the internet also, is it 5 minutes, if it's 30 minutes, it's 5 minutes now, more practical definition. Okay. Now a patient who comes to my emergency room who has been having alcohol regularly and stops drinking the alcohol, throws up a seizure, is known as an alcohol withdrawal seizure, C2H5OH withdrawal seizure. So patients with alcohol withdrawal seizure need not be given anti-epileptic drugs in a regimen. They need to give benzodiazepine, which is possibly in a government setup diazepam injection, in a private setup maybe a midazolam injection. So in patients with alcohol withdrawal, a very simple question, first drug that you need to give is always a benzodiazepine, and the only drug. You need not give an anti-epileptic for these patients. Write down a question on this. A known alcoholic is brought to your emergency by his wife. Very important statement. If the police wala gets him to the casualty, he must have been fallen on the road. His wife is getting him to the casualty, there is a disease possibly. The person has not consumed alcohol for last 2 days due to religious reasons. Oh God, must be dry days. He complained of nausea, vomiting, followed by 2 episodes of generalized tonic-clonic seizure. Treatment: valproate, diazepam, phenytoin, clonidine. What's your call on this? A known alcoholic is brought to emergency by his dear wife. He has not consumed alcohol by the God's grace due to religious reasons. He complained of 2 episodes of seizure. Possibly we are dealing with a case of alcohol withdrawal seizure, and the drug of choice in such a setting is only diazepam. Don't use an anti-epileptic drug so early. Okay, simple question. Now we'll proceed. Now if we want to manage a patient with status, how do we manage the patient? If you want to manage the patient with status epilepticus, the first anti-epileptic that you need to give is always lorazepam, a sedative kind of a drug, lorazepam. In a lorazepam, if it is not very successful, you start your therapy with phenytoin. Phenytoin is given at a dose of 20 mg per kilogram of body weight IV at an infusion of 50 mg per minute. If the things are not very done, then again you use phenytoin. Phenytoin this time is given at a half dose, 10 mg per kilogram of body weight. Still not very happy and still not the seizure controlled, and in that case valproate. Valproate is given at a dose of 20 mg per kg per body weight, 25 mg per kilogram of body weight. If still seizure don't subside, then you can use phenobarbital, 20 mg per kilogram of body weight. If seizure don't subside, then again you use phenobarb, 10 mg per kilogram of body weight. Seizure don't subside, then you use midazolam, propofol, and thiopentone. So that's a protocol of managing a status. Someone had asked me that phenytoin full dose is not very successful. Why half dose then? See, this is a protocol. No good reason I could myself get in the textbook. Why full, not why and half then later. See, this was a protocol that was followed for around 1000 patients in America and UK. How to manage a status, and they came on a consensus like this. So there are few steps that you need to start with: lorazepam, phenytoin, full, half, valproate, full, half, midazolam, propofol, thiopentone. Someone had asked me that day, if midazolam and propofol are so good a drug, why are they given on the last? Why not they given on the first day? See, one thing I'll tell you, propofol, midazolam, thiopentone are general anesthetics and muscle relaxant. If you give these drugs, they may paralyze the patient so badly he or she requires a ventilatory support to breathe. Ventilatory support not always available with us, so becomes a big trouble. So we use it on the last, not on the very beginning phase. One easy question. Drug of choice for status epilepticus, a very old question that we know, that is lorazepam. One anti-epileptic that you cannot give possibly is carbazepine. Carbazepine is not given because unfortunately carbazepine is available in a form of an oral congener. Okay, it's not an IV injection. So things like intravenously given are given for such patient, not oral tablet like this. Now extra nail in the coffin that we need to know. What are the other modalities of treatment of seizure disorder apart from the anti-epileptic that we know? What are the other modalities that we need can be done for the patient? Number one, epilepsy surgery. We already did this thing done in patients with temporal lobe epilepsy. We did a surgery, temporal lobectomy. Number two, ketogenic diet. A high frontal topic which is more of a theoretical, less of a practical thing. In ketogenic diet, we tell the patient not to eat anything much, starvation, for maybe 1 or 2 days, and we start feeding the patient on a high fat and a low carbohydrate diet. As soon as the patient starts taking such a diet, then there is a high tendency of ketone bodies getting formed. Ketone bodies have got one tendency, they have been found that they inhibit the epileptic focus. So there has a tendency of the ketone bodies, whenever they are found, they inhibit the epileptic focus. So in patients who are not very successful with the anti-epileptic drugs, you try your therapy with ketogenic diet. Simple. What was the question this season was that which anti-epileptic drug should not be used on a patient with ketogenic diet? Answer is valproate. Don't use valproate. See, valproate has got one bad side effect, pancreatitis. Even with ketone bodies, pancreatitis can occur. It may not become 1 in 111 this time. So avoid using valproate in a patient who has ever been on a ketogenic diet. Who is on a ketogenic diet, never use valproate. Number 3, again a theoretical thing which is known as vagus nerve stimulation, well abbreviated as VNS. In this, we stimulate the vagus nerve, that is the 10th cranial nerve. As soon as we stimulate the vagus nerve, we have found that it inhibits the epileptic focus. So we can also have a surgical thing done, we stimulate the vagus nerve, it inhibits the epileptic focus. So we have got 3 things. In the patient who is not very treatable with anti-epileptic drugs, epilepsy surgery, ketogenic diet and vagus nerve stimulation that can be done for the patient. Out of the 3, the best is epilepsy surgery. The best therapy is epilepsy surgery. Okay. So this was an interesting question in AIMS put to you around a year back, that in a patient with medically intractable seizure, which of the following modality of treatment is best in making the patient seizure free? That means in a patient who is not very amenable to medical treatment, what is the best is always a surgery. They have done a good trial in which they have compared the epilepsy surgery with ketogenic diet with vagus nerve. They found that epilepsy surgery has got the best result. Okay. Now note down a question on this, not on this but something different. Write it down. Which of the following features is helpful in distinguishing seizure from syncope? Option A, loss of consciousness. Option B, injury due to fall. Option C, urinary incontinence. Option D, physical weakness with clear sensorium. Which of the following is helpful for distinguishing a seizure disorder from a syncopal attack? LOC, urinary incontinence, injury due to fall, physical weakness with clear sensorium. Good, you know the answer, most of you. I'm very surprised because half knowledge is always dangerous, I believe. If you ask someone as an MBBS graduate what is the distinguishing point, he'll come with an answer. Sir, urinary incontinence. Why? Half knowledge. You thought that urinary incontinence occurs in seizure. No, it occurs also in syncopal attack. Something wrong. Loss of consciousness occur in both of them. For a seizure it may go for a longer time, for a syncopal attack for a lesser time. Injury due to fall, I believe, is something called imaginable at your end. It can occur in both of them. What should be the answer? For this answer, I have got a good answer for this. It's not in the book. I'll share one experience with you guys. I was standing in a queue in the bank, and there was one uncle ji, which was actually standing in front of me, and he was wiping off his sweat, pasina, and he was coughing all the time. Must be Mr. Kejriwal, maybe. I've not recognized him. So he was coughing and he was sweating out. He was standing. Suddenly, he had a large bout of cough, and he fell on me. As soon as he fell on me, I saw him moving and shaking, tonic-clonic movement. I saw the pants going wet, urinary incontinence. So as a physician, I know that this is having a seizure disorder. I made him flat on the floor and made him in a left lateral position. And the people around me, if they see a seizure, they do all lot of things. You must be seeing in the ward even. They come with a shoe, they come with a onion, they come with something else, make him smell, all these things. So I told everyone, make him in a non-dangerous, comfortable position, left lateral position. Suddenly around just a minute had passed off, and bank manager came running to me and told me, what are you doing? Mega, he's having a seizure. He said, no, he's one man who faints every day. He made him flat on the floor, raised his foot end, and within 2 seconds he was totally normal. When the patient became totally normal, we asked him what happened. He told me everything clearly. He told me that he was standing in a queue, he was sweating a lot, he did not have breakfast in the morning. On top of it, he is a known diabetic. His doctor has told me once upon a time that don't stand in a hot climate for a very long time, you will faint. One thing which we know is orthostatic hypertension kind of a story. So he had an hypertensive episode that created hyperperfusion in the brain that resulted in a syncopal attack. Even a syncopal attack can have tonic-clonic movements like a seizure for a lot shorter duration, not for a longer duration as a Caesar ran. He had incontinence, everything. But one thing that he had was a clear sensorium. Very perfect. He knew everything in a sequential order what happened, and he had some physical weakness. So one thing which he could understand is that physical weakness with clear sensorium goes more in favor with a syncopal attack rather than a seizure. A patient with seizure won't have such a kind of a story very often. Okay. So that completes most of the things that you need to know about seizure. Any doubts from your end? I am actually purposefully disabled the chat because I've seen most of the student, I write one line, they come with a doubt. It interrupts the flow. We can have the doubts at the end, no problem. Salam spells. I was waiting for this one. Jammu salam spell. See, this is something done in pediatrics. I'm not sure the pediatrics class is over with you. Voice problem. Voice. Yeah, tongue bite. Pune Center. If tongue bite is option between no, tongue bite can occur in both. I've seen a patient with syncopal with a tongue bite. Okay, tongue bite is not very. See, tongue bite is specific for seizure versus pseudo seizure. You read something else. Pseudo seizure wala patient will not have a tongue bite very often. Seizure disorder has got a tongue bite. So differentiating a pseudo seizure from seizure, tongue bite would be good. Hyderabad, any precipitating factor for absent seizure? Hyperventilation precipitates. Okay. Salam seizure, salam spells. Actually, salam spells. Salam means someone doing salam. Otherwise, so we had a patient who was getting stiff and is moving his body in the arms like this as if he's doing a salam. Salam spells. Salam spells are also known in the book as infantile spasm, as it was seen in the infants, and in the higher book known as West epilepsy. So we got a different thing in the infants, infantile spasm or West epilepsy. That's the only thing. It looks like someone doing Adha Varze or Salam. Now the thing is that what is the drug of choice? Tell me an answer for this one. Drug of choice for West epilepsy, Salam spell or infantile spasm? Chalo, rhythm correct, I believe. It's not vigabatrin, because I've read some guide mentioning vigabatrin. I was getting paranoid on this. ACTH, there's a line in neurology book that steroids like ACTH, prednisolone are the drug of choice. If the patient is having tuberous sclerosis, that was an associated finding with the patient, then in that case we used vigabatrin. So if you're reading a famous pharma guide, he mentions the answer is vigabatrin, wrong answer. The answer is ACTH, simple answer. Okay. Chennai Center, drug of choice for seizure in a patient with hepatic incaf problem. I believe, see, it's a physician's choice on his end. Valproate is hepatotoxic, cannot use valproate. Phenytoin again hepatotoxic. Why not use phenobarb? Phenobarb is an enzyme inducer. It can get rid of the bilirubin from the liver, but it has to be very cautious one because phenobarb itself causes sedation. So there is no consensus on drug of choice in patients with hepatic incaf. See, hepatic incaf patient most of the time present with myoclonus. So myoclonic seizure drug of choice was valproate. We use valproate at a lower dose, not very high dose. Okay, if the patient is not very sedative, we can use phenobarb again at the low dose. But there is no consensus on drug of choice for seizure for hepatic incaf. Lennox-Gastaut thing we'll discuss in pharma and pediatrics. Okay. Which is most epileptogenic, Chennai Center? I'll come to this when I discuss stroke. Don't worry. I'll discuss this topic then. That will have more relevance there. Okay. Chal. We'll start with a new topic then. Movement disorder. Movement disorders are basically disorders that arise from someone's subcortical, that is basal ganglia. Like you know that the cortex sends a message for the body, makes up an impulse in the cortex, it goes down through that corticospinal tract and is taken to the body. Now there is someone below the cortex that regulates the movement, the timing that has to occur. The timing word is something that is a preciseness of the movement. I catch an object, my hand goes straight, I don't catch it very fast, I don't catch it very slow because I have a sense of timing in me. The timing sense comes from someone's subcortical. That subcortical structure that regulates the timing of a movement is basal ganglia. So basal ganglia lesions, secluded nuclear lesions can paralyze. Yes, I can understand putamen lesion can paralyze the patient, but somewhere in the caudate lobe, caudate nucleus can cause a movement disorder which is not paralysis, but the movement goes haywire. It is fast and slow kind of a story. Okay. The very first in the list is ethetosis. Ethetosis movement is defined as a slow sinus writhing motion. Slow sinus writhing motion is known as ethetoid movement. They are very often named as a crawling kind of a movement that the patient happens to see. Like the hand goes straight, the hand goes shaky all throughout. It's a crawling kind of a movement. If you've seen a snake crawling on the floor, it looks like this. It's going slow and it is crawling on the floor. It's a crawling snake-like movement that is known as ethetoid movement. Now, where is the lesion in the basal ganglia zone? It is in the globus pallidus. This was a famous question, that where is the lesion for ethetosis is in globus pallidus. The mnemonic for that is gap. Ethetosis A between the two GP, globus pallidus. Globus pallidus in between ethetosis, the mnemonic for that is gap. So ethetoid movement occurs due to lesion in globus pallidus. Second movement disorder that you need to be aware of is chorea. Chorea is defined as a semi-purposeful movement. Chorea is defined as a semi-purposeful movement, also very well labeled in the book as a dance-like movement. So if I am catching an object and I shake my hand on the body as if I am going to do a dance, that is known as a dance-like choreoid movement. The lesion for chorea occurs in caudate nucleus. C for chorea, C for caudate nucleus. Caudate nucleus lives in this part of the brain, corpus striatum. So lesion of caudate nucleus occurs, lesion in caudate nucleus causes chorea. Lesion in corpus striatum also causes chorea. So there was one easy question in AIIMS long back, that chorea occurs due to lesion in caudate nucleus. DNB board this time has asked a different question, that lesion in corpus striatum causes chorea. Okay, so corpus striatum is a bigger part that accommodates caudate nucleus inside it. So lesion in corpus striatum also causes chorea. This season we got one more question, what are the causes of chorea? The causes of chorea is chorea. Chorea during pregnancy, chorea gravidarum. Huntington chorea. We'll discuss this disorder in detail. Use of oral contraceptive pill. Rheumatic chorea. It is also known as Sydenham's chorea. Endocrine disorders. Like thyrotoxicosis and atherosclerotic or senile chorea. chorea gravidarum, Huntington's chorea, OCP, rheumatic synonyms, thyrotoxicosis, atherosclerotic or senile chorea. These are the 4 causes of chorea that you need to be aware of. Another movement disorder, that is hemibellismus. Hemibellismus is known as a large amplitude flinging movement of the proximal limb. So if you have got a shoulder joint moving away like this, flinging movement that is of a large amplitude, that is known as hemibellismus. Okay. So bellismus was a term that include a large amplitude flinging, someone waving his shoulder joint so badly, large amplitude flinging movement of the shoulder, proximal limb, okay, is on one side hemibellismus. Hemibellismus occurs due to lesion in this part of the brain, subthalamic nucleus, STN, subthalamic nucleus. It occurs due to lesion in subthalamic nucleus. Now, father of all movement disorders, Parkinsonism. Parkinsonism basically occurs due to fall in the dopamine level in the brain. It's a receptor which is alright, it's a level that falls down, and rise of acetylcholine. Fall in central dopamine level in the brain often produces rigidity. Rise in acetylcholine central in the brain often causes tremors. So we found that the patient was having rigidity and was having tremor. That was something in synonymous with Parkinsonism patient. The reason is all in front of you. Now why does Parkinsonism occur? It occurs due to lesion in this part of the brain, that is substantia nigra pars compacta, well abbreviated as SNPC, substantia nigra pars compacta. This part of the brain undergoes degeneration and causes Parkinsonism. Etiology. If I want to look at the cause of Parkinsonism, etiology, number 1, drugs. Drugs which I believe I do use day in day out are dopaminergic antagonists, which are blocking the central dopamine receptor. One of the very famous is typical antipsychotics, like all that haloperidol, all that typical antipsychotic drugs. Another one is a antiemetic, that is metoclopramide. So these are two dopaminergic antagonists that you use in day-to-day practice, injectable and oral. A use of them can cause Parkinsonism. Number 2, toxins, carbon monoxide and manganese. Carbon monoxide and manganese would really do well. 2 toxins, carbon monoxide and manganese. Big C, big O, carbon monoxide, M and manganese. Number 3, a very famous cause, for one reason, a very famous American boxer suffers with Parkinsonism, Muhammad Ali. He was boxing without that foam guard on the forehead. So every time he used to get this punch injuries, punch drunk kind of a story, it created a blow on the head, it created degeneration in the substantia nigra region. So repeated blows on the forehead, especially in patients who are boxers, have been found as an antifibril cause. So in boxers we see trauma as an antifibril cause. Number 4, last but not the least, idiopathic. The word idiopathic means unknown. Doctor is idiot and the patient is pathetic. Okay. They found that around 75% of the patients of Parkinsonism don't have an identifiable cause. So idiopathic cause happens to be the most common type or the most common cause of Parkinsonism. The idiopathic Parkinsonism is also known by the term Parkinson disease. It is also known by the term paralysis agitans. See, whenever you read the topic Parkinsonism, you never see the heading as Parkinsonism. You always see the heading as Parkinson disease. Other heading is sometimes old book paralysis agitans. Okay. So idiopathic Parkinsonism is the most common type of Parkinsonism that you see in the patient. Now, another MCQ one-liner. Most common cause of acquired Parkinsonism, that is secondary, is drugs. Most common cause of secondary Parkinsonism, that is out of some cause, is always a drug. Drug happen to be the most common cause of secondary Parkinsonism or acquired Parkinsonism. Clinical features. If I want to see this disorder in a form of a clinical feature, I see it in a form of a love triangle or a clinical triad. On the top I have got tremors. Secondly, I have got rigidity. And the third that I have got is slowed movement known as bradykinesia. So we got tremor, we got rigidity, and we got bradykinesia in the patient. The type of tremor, that's a first important signal. First and the most common symptom of Parkinsonism is always a tremor. The type of tremor that you possibly see is a resting tremor, which comes in a frequency of somewhere 4 to 6 hertz. So it's very often a resting tremor that you see in the patient with a frequency of 4 to 6 hertz. Like someone is rolling his hand round at rest, that is known as a resting tremor. Okay, so they have a tremor at the rest only. When they take and hold an object, it suddenly disappears. So that's the word meaning of resting. It is static, it is resting only at rest. But sometimes we see a patient in our ward who moves his hand near the object and starts shaking it. That is known as intentional tremor. So very often we see patients with hand shaking on reaching the object. The word that we use is intentional tremor. So other types of tremor, one of them intentional tremor, that is seen in patients who are having a cerebellar lesion. So in patients who are having the lesion in the cerebellum, that subcortical structure has got an intentional tremor. This question was picked up in the AIIMS pattern this season on a computer, because the AIIMS paper now is on a computer, so they have a liberty of using images and all that things, because on a paper bound it's very difficult to put an image sometime. So they have shown a square. You know what they did? They were drawn a 4 lines, 4 dots, and they would ask the normal patient to join the dots and make a good square. That was a normal square. You and me will join the dots normally and make a perfect square, but a patient who is having a cerebellar lesion or an intentional tremor, we start from one point, we reach the other point, on reaching it he or she shakes it. So we get a zigzag on terminal part, that I am telling you as the word intentional. They move the hand on reaching the object, intentional. They again start, they again start moving, they again start, they again start moving, they again start, they again start moving. So we got a lot of zigzag all throughout at the terminal part, that signifies the patient is having an intentional tremor and the lesion is in cerebellum. So that was a question this season in AIIMS, that a patient has been shown with a normal square, yes, and a patient was coming to me with a zigzag at the terminal part. It signifies that the patient is having an intentional tremor, a lesion in the cerebellum. Very simple answer. Other kinds of tremor that we see in clinical practice, one of them is flapping tremor. Flapping, you know, the bird is flapping her wings. So if I am holding the hand straight and I am dorsiflexing the hand like this, and the hand moves like this, down, 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 down. Every time I am doing this, it moves down, 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 as if I am flapping, or the wings are flapping. Flapping tremor is also known by another term in clinical practice, hysterexis. Flapping tremor, if you remember, is occurring in patients with hepatic encephalopathy, in patients with uremic encephalopathy, in patient with CO2 narcosis. That means a patient who comes to me with high carbon dioxide in the blood, that is type 2 respiratory failure patients, CO2 narcosis, that is respiratory failure. Renal failure, hepatic failure and respiratory failure, these are 3 causes of flapping tremor. Another term that we use is fine tremor. Fine tremor is something which is very fine, you don't see it, but you make the patient outstretch the hand. On outstretching the hand, they suddenly start shaking it at a very fine movement. fine tremor. That is very often seen in patients with hyperthyroidism. I'll put the word as thyrotoxicosis. So in patients with thyrotoxicosis you see fine tremor. This was a question in AIIMS last November, that in an old patient with coarse tremor, which of the following is not a diagnosis? The answer is thyrotoxicosis, because thyrotoxicosis often has got a fine tremor. This season we got a square. So in AIIMS I believe they are resting themselves somewhere on the tremor. You are bound to get another question in November at least this season, that on a tremor. They might ask you a cause, they may give you a square like this. Now the second feature symptom that we see, or a sign, is rigidity. Rigidity is defined as a resistance to passive movement. So if you're moving my elbow joint, like if this is the hand and you're moving my elbow joint and you feel that the movement is perfect, yes, perfect, normal, but the movement is less, that is there is some resistance that you see on the movement in the elbow joint, that is known as rigidity. Sometimes the movement rigidity will be same all throughout, sometimes with jerk in between, and sometimes the rigidity is seen initially and then it opens up. So the rigidity is same all throughout is known as a lead pipe rigidity, as if you are molding a pipe. If it is a jerk in between, it is a cogwheel rigidity, and if at all it occurs initially and then opens up suddenly, that is known as clasp knife rigidity. So the rigidity has been defined into three types: same all throughout lead pipe, with jerks in between, cogwheel, initially present and then later opens up, clasp knife. So we know that lead pipe, cogwheel and clasp knife rigidity, three kinds of rigidity: lead pipe, cogwheel and clasp knife. Lead pipe rigidity is seen in extra pyramidal syndrome, EPS. Cogwheel rigidity is seen in Parkinson disease. Clasp knife rigidity is seen in upper motor neuron lesion. So in patients with upper motor neuron lesion you get a clasp knife rigidity. Cogwheel rigidity is seen in Parkinson disease patient, and lead pipe rigidity is seen in extrapyramidal syndrome. Someone had asked me, sir, Parkinson disease is also extrapyramidal kind of a story. Why not lead pipe there? See, initial phases you get lead pipe, but when tremors come into the picture, they make the story cogwheel. It comes with a jhatka in between or a jerk in between, cogwheel kind of a story. If someone puts me a question, what kind of rigidity do you see in Parkinson disease? I'll always mark it as cogwheel and not mark it as lead pipe. Now something interesting, that the patient walks around with a different kind of a story, that is known as a gait. The gait that you possibly see in the patient is known as a festinating gait. What do we mean by the word festinating? Like you and me, when are walking on the floor, we are very perfect in our gait. We'll move with a good arm swing, good leg swing everywhere, we'll be happy to walk. But a patient, if I see it in a lateral view of a Parkinson disease, they firstly have got a stoop posture. Firstly, they have got a stoop posture. They have got a flexed body like this. They bend slightly interior and downward because of rigidity. And when I and you move the lower limb, we move it so perfect. We have got a good leg swing, good arm swing. Yes, but a patient with Parkinson disease is first of all rigid, flexed. He or she cannot move the legs so properly. So when they walk, like you and me walk, we keep the left and the right leg at a distance and we walk properly. But a patient with Parkinson disease, left and the right leg will not have that much of a distance. They will be almost of the similar kind of a distance, a very short distance. So they have a habit of taking short frequent steps. The word is short, frequent, fast steps, as if they are ready to run somewhere. As if they are ready to run somewhere. The word ready to run in English language means festinating. So the festinating gait means ready to run somewhere by taking short frequent steps while walking. That is a typical gait that you see in patients with Parkinson disease. In patients with Parkinson disease, they've got a different problem also, which is known as Kinesia paradoxa. Kinesia paradoxa. Paradoxa means opposite, kinesia means movement. So we have a patient of Parkinson's disease who was walking slowly, but when they start running, they apply the fifth gear and shoot out like a rocket. So we had a patient of Parkinson's disease with a good acceleration. So when they start running, they apply the fifth gear and they shoot out like a rocket. A good acceleration. A very good acceleration component seen in a patient of Parkinson's disease is known as opposite, kinesia paradoxa. So kinesia paradoxa is something that is seen in patients with Parkinson's disease with a gait, short frequent steps which are very fast as if they are ready to run somewhere, known as fascinating gait. Now apart from all these things, what happens is you and me are running, we stop, we stand straight, we balance the body. But a patient of Parkinson's disease starts running, stops and he falls. You and me stop and stand. Why? We extend the body, we make the body straight and we balance the body. But these patients cannot balance it. Loss of postural reflexes. So there has been a finding in a patient with Parkinson's disease that when they suddenly stop, this fall. For one reason, they cannot balance themselves on sudden stopping. They don't extend the spine, they are having a flexed posture. So they have got a loss of postural reflexes. With all the things said and done, they've got a smaller handwriting which is known as micrographia. They have got a speech that is all same throughout, monotonous speech. They have got a face that is often not changing expression, known as mask-like face. You've got depression and they've got dementia. So patients with Parkinson's disease, apart from the clinical triad of tremor, rigidity and hypokinesia, have got loss of postural reflexes, micrographia, monotonous speech, mask-like face, depression with dementia. Now the problem is not to understand this topic, the problem is to understand this topic, Parkinsonism plus or atypical Parkinsonism. A patient of Parkinsonism with some extra problem, with some unusual problem, atypical. Number one is Steele-Richardson syndrome, also known by the term progressive supranuclear palsy, PSP, progressive supranuclear palsy or Steele-Richardson syndrome. In this patient, it's just the opposite of what we saw. They are not having a flexed posture. These patients are having an extended posture. They extend the spine. They are unable to look down. They are having a defective downward gaze. If they are not looking down, they are walking straight with an extended posture. I am very sure they will hit an obstacle and fall down because they cannot look down. They have got history of fall with memory loss, which is known as dementia. They have got an extended posture, defective downward gaze, fall with dementia. One thing which they lack is tremor. Tremor was the first most common symptom. So idiopathic Parkinsonism has got a tremor phenomena with it. But if they don't have tremor, it is wrong, atypical. They've got an extended posture, defective downward gaze, that comes as a plus for them. Okay. So PSP patients differ from Parkinson's disease for two reasons: extended posture, defective downward gaze, and the third reason is lack of tremor. Tremor, the most common essential, is lacking in patients with PSP. Second disorder plus atypical type that we see is multiple system atrophy. MSA. These are patients of Parkinsonism who come to me with autonomic instability. Usually a patient of Parkinsonism never came to me with orthostatic hypertension, reflex tachycardia, bradycardia and changing the posture. If they start having such a event, then it is autonomic instability. That is wrong, atypical, that is a plus, MSA. So patients with extended posture, defective downward gaze, fall, dementia, lack of tremor comes into a form of PSP, progressive supranuclear palsy. Patients with Parkinsonism with some autonomic instability fall into one category, multiple system atrophy, MSA. Now, treatment. I'll not dig into like a pharmacologist does. I'll just give you an overview on this treatment. The reason of having Parkinsonism was decrease in dopamine and increase in acetylcholine. Two reasons: decrease in dopamine and increase of acetylcholine. Decrease of dopamine is bound to cause decreased flexibility in the body, which is known as rigidity. Increase of acetylcholine causes tremors. So one thing I could do, I could give a precursor of dopamine that could easily cross the blood-brain barrier and make the patient well and walking, levodopa. Levodopa I give to the patient starts walking on, but after some time you saw that dopamine was eaten up by enzyme, central and peripheral, so the patient became off. So patient of Parkinson's disease was given levodopa, he starts walking on, but after walking maybe for 1 hour, he again stops off. Why? Because the dopamine that was formed from levodopa was eaten up by enzyme, central and peripheral. So with levodopa therapy, we give certain enzyme inhibitor. One of them is peripheral decarboxylase inhibitor, a very famous, carbidopa and benserazide. Okay. Number 3, C-orthomethyl transferase inhibitor, COMT inhibitor, entacapone and telecapone. Number 4, monoamine oxidase B inhibitor, MAO-B inhibitor. A good example, siligilin and resagilin. Number 5, we can also give one drug which is antiviral, amantadine. You might wonder that Parkinson's disease is not a viral problem. Why amantadine would really work in this patient? Amantadine has got one side effect. It increases the central dopamine level. So it may be a benefit for the patient. Okay. Number 6, you can also use certain drugs which are central dopamine agonist. Because the receptors are alright, we'll give certain drugs which will act centrally and start making the dopamine receptor work there. Okay, so the rigidity phenomenon should come down. Central dopamine agonist, D2 receptor agonist. A good example, old example, pramiprazole. A newer example, ropinirole. A better example, rotigotine. What's so better in this? Rotigotine is available in a form of a transdermal patch. You stick it on the patient, patient benefits, transdermal patch, rotigotine. Number 7, apomorphine. Morphine was actually a central dopamine agonist, but use of morphine will cause sedation. So we use something, a congener of morphine, non-very sedative, apomorphine. So it's an injectable drug, one thing, a benefit. Why? A patient who comes to me with severe off, I want to get him on. I give oral tablets, they will take 2 to 3 hours time, I am very sure. But an injection will take some 2 to 3 minutes time. So a patient who came with a severe off, I want to make him walk, I make him on. I give him injection of apomorphine and he comes out from that off. This apomorphine comes as a drug which is rescuing the patient out. The word is rescue therapy. So that's a old pharma question. The rescue therapy drug of choice for Parkinson's disease is apomorphine. Okay, it comes like a Sanjeevani booty for the patient. Rescue therapy drug of choice is apomorphine. Number 8, I've got a tremors because of rise of acetylcholine, so I give anticholinergics. Anticholinergics, a good example, centrally acting trihexyphenidyl. Centrally acting anticholinergic trihexyphenidyl that is used for the patient. If someone puts me a question, answer this one. Drug of choice for Parkinson disease, levodopa or dopamine agonist? You got two choices. One, levodopa, and the second is dopamine agonist. As per your knowledge, what should be the drug of choice, levodopa or dopamine agonist? Chalo, I think so. The rhythm is still correct, and we understand that there is levodopa always, which is given to the patient. Drug of choice is always levodopa because the old edition of Harrison mentions dopamine agonist as drug of choice, but the newer edition, 18th edition, mentions that old is gold. Levodopa is the best, first, and the gold standard drug to be tried for any patient with Parkinson disease. So you start your therapy always with levodopa. Drug of choice is levodopa. Now something extra. Apart from the medical treatment, nowadays we are going for surgery also. Surgical treatment. Indications, one indications. Number one, intractable tremors. Normally we have got tremors in a patient with Parkinson disease, you give anticholinergics, tremors subside. But the thing is that the patient is not having any benefit with that anticholinergic therapy. The things become intractable tremor. So patients who are of Parkinson disease not benefiting from anticholinergic drugs go into one type which I know as intractable tremor, which are not benefited by anticholinergic drugs. Number two, the biggest challenge is this, drug induced dyskinesia. You give levodopa to anyone, it becomes dopamine and it stimulates the dopamine receptor. But suddenly we found in clinical practice that it starts blocking the receptor. Instead, the levodopa went inside, instead of stimulating, it starts blocking the receptor. So I have a patient on levodopa therapy on, but after few days of months of therapy, I found that the patient with levodopa became off. The off reason for this time was not the dopamine getting down, it was the levodopa, instead of stimulating, blocking the receptor. So we have got a garbad, we have got a dysfunction, dyskinesia of the movement because of the wonder drug levodopa. So patients who are on levodopa therapy shows worsening, that is known as drug induced dyskinesia. In that stage we go in for a surgery. The surgical procedure is not too invasive kind of a story. The thing that you need to just know the name, deep brain stimulation. Deep brain stimulation, well abbreviated as DBS. Deep brain stimulation to be done for two regions in the brain. One is subthalamic nucleus and the second one is globus pallidus interna, GPI. Globus pallidus interna and subthalamic nucleus are the two areas which are taken for deep brain stimulation. Subthalamic nucleus is taken up for the deep brain stimulation when you have got an intractable tremor. Globus pallidus interna is taken for deep brain stimulation when you have a drug induced dyskinesia. So patients who are having drug induced dyskinesia, we have to do a DBS, we do it for globus pallidus interna area. If you have got intractable tremor, you go in for subthalamic nucleus stimulation, DBS, deep brain stimulation. Okay. It's just imaginable thing, you know. You must have seen a pacemaker for the heart. The battery is in here and the wire goes into the brain, but this time the battery is here and the wire goes, sorry, the in the pacemaker of the heart the battery is here and the wire goes into the heart. This time the battery is here and the wire goes into the brain. That is known as deep brain stimulation. Okay, DBS. So that was an AIMS question that we faced around 2 years back in a patient with intractable tremor in Parkinson disease. Deep brain stimulation is to be done. Which area is preferred? STN. So any doubts? Someone in the Mumbai center had asked me what is Shy-Drager syndrome. You know, in 18th edition, latest one, they removed the word Shy-Drager. What I am telling about MSA, multiple system atrophy, those things are earlier known as Shy-Drager syndrome. So multiple system atrophy had an old name, Shy-Drager syndrome. This all has been replaced recently by the name MSA only. Okay. Most common complication of DBS, depression. We could find depression as one of the common complication of DBS, depression. Investigation, Jammu Center for Parkinson disease, very smart. By Parkinson disease is diagnosed only on clinical basis. There is no MRI. Okay, even if you do a brain biopsy, maximum you could find a Lewy body inside it. Bas, that's it. You don't do a dopamine level in the brain. You don't see the blood dopamine acetylcholine level. No, no, nothing. Blood test, no LP, not a good MRI, but something which is very basic is clinical. A patient who comes with resting tremor, cogwheel rigidity, fascinating gait with bradykinesia goes into favor of Parkinson disease. Okay. Contralateral subthalamic nucleus. Okay, hemibellus is contralateral. Levosulfide leads to Parkinsonism. Okay, what is percentage on it? I need to check it. Must be the DNB question. I'm very sure. I need to check it and I'll answer you this in the next class. I'll write it down. Drug of choice for drug induced Parkinsonism. Okay. See, I'll tell you, uh, very often we see patients who are getting a metoclopramide injection in the ward, Perinorm, and going into dystonia, that is dopaminergic antagonist. For such a patient, we give promethazine. Promethazine is an injectable Finargan injection very often. That's an anti-allergic kind of a thing, but it has got one side effect. It actually increases the dopamine level again. It starts unblocking the dopamine receptor. So in patients with drug-induced Parkinsonism, we often give this promethazine kind of a drug. But I'll check it on this again in the pharma section if they differ on this. Okay, Hyderabad Central, I answer you in the next class. I need to read it from the pharma book, drug of choice. Now one more question. Coffee break. Option A, yes. Option B, no. What is your answer? Coffee break? Yes. Okay, okay, okay. No, Shimla Center? No. Duration? A, 5 minutes. B, 10 minutes. C, 30 minutes, 15 minutes. D, 0 minute. Okay, okay, fine, fine, all right. अरे बाप रे बाप, fine, fine. और ठीक ठीक ठीक, बस बस, थाम थामा थामा थामा, बस बस. चलो, we'll take a 10 to 15 minutes coffee break. We'll come back. Okay. चलो, let's restart. Now we'll consider the discussion on another very important topic of neurology, high yield topic in the MCQs, cerebrovascular accident, also known as stroke. Cerebrovascular accident, also known as stroke. CVA or stroke is defined as a CVA or cerebrovascular accident or stroke is defined as a focal neurological deficit due to vascular cause. Now we understand that there is a brain vessel supplying blood to the brain. Suddenly it stops working due to certain clot or hemorrhage and it is unable to supply blood to the brain. Brain doesn't get the blood, doesn't get any nutrition, doesn't work. As a result, the patient faces hemiparesis, aphasia, amnesia, anything that is a focal neurological deficit. This drama, if it is there for a duration of more than 24 hours, if it is for a duration of more than 24 hours, that is known as stroke. Okay. If the same thing comes to me for a duration of less than 24 hours, is known as TIA or transient ischemic attack, TIA. It is for a duration of less than equal to 24 hours. So for the definition of stroke, it has to be there for more than 24 hours. For a definition of TIA, it has to be there for less than 24 hours. Now the question is this: the most of the TIA are of 1 hour duration. That was an MCQ this season, that most of the TIA are of what duration? 1 hour duration. Okay. Stroke more than 24 hours, TIA less than 24 hours, but most of the TIA are of a 1 hour duration. Now, how do we classify stroke? The classification is a very basic funda that the brain vessel is supplying blood happily to the brain. Suddenly a clot comes and sits inside it, and sometimes what happens is the vessel ruptures and the blood moves out. So the blood moves till this part, not any further. Here the blood moves out, not any further. So there are two etiologies of stroke that we get. One is an ischemic stroke and the second one is hemorrhagic stroke. Ischemic stroke, 85% of the strokes are ischemic stroke, 15% of the strokes are hemorrhagic stroke. This clot might come from some other source, it is embolic, or this clot might be formed in situ, it may be thrombotic. So ischemic strokes are again divided into embolic and thrombotic. %75% of the strokes that we know are embolic stroke, 35% of the strokes that we know are thrombotic stroke. So most common type of strokes that we know are embolic strokes. Not the thrombotic stroke given in one of the guide, it's embolic stroke which is the most common type of stroke. More common type of strokes are ischemic stroke rather than hemorrhagic stroke. Now one more question. Most common cause of embolic stroke is atrial fibrillation, AF. Atrial fibrillation is the most common cause of embolic stroke. Now one more MCQ. Most epileptogenic stroke. A stroke that is happening causing the seizure more often, most epileptogenic are embolic stroke. Number 2, hemorrhagic. Number 3, thrombotic. Most epileptogenic strokes are embolic stroke. Number 2 are hemorrhagic stroke. Number 3 are thrombotic stroke. So we know this fact that most epileptogenic strokes are embolic strokes. Most common cause of embolic is AF, and the most common type of strokes are embolic stroke. Okay. Now before going into the topic proper of stroke, let's see the basic anatomy physiology, the lobes of the brain and what function do they really perform. We start with the very first one, frontal lobe. Frontal lobe has got one area in the brain which is known as a primary motor area, also known as a Brodmann's area. Primary motor area, also known as a Brodmann's area. Primary motor cortex or the Brodmann's area is making any motor command to start. So whatever motor command I do, I move my hand, I face anything, starts appear in the frontal lobe in the motor area, Brodmann's area. If you draw a section of the Brodmann's area, I draw a coronal section of this Brodmann's area. I see the body being represented on it like this. The medialmost is the lower limb. Then comes the trunk, arm, forearm, and a bigger hand. And after this, the face. Every time we see the diagram, we see it like this. The hand, the face, and even the tongue is having a larger area of representation as compared to the trunk, the lower limb. Why? Because we know that finer the skull, larger is the area of representation. So finer the skull, larger is the area of representation in the Brodmann's area or the motor cortex. Okay. One easy one-liner on this. Which part of the body is having the largest area of representation in the motor cortex? Okay. Write it down. Which part of the body is having the largest area of representation in the motor cortex? I'll give you option. Shoulder, shoulder joint. Option B, elbow joint. Option C, wrist joint. Option D, metacarpophalangeal joint. Shoulder joint, elbow joint, wrist joint, metacarpophalangeal joint. Simple answer, correct answer, metacarpophalangeal joint, because the hand is having the largest area of representation in the motor cortex. Okay, so it's a very easy question that you can solve at this point, because finer the skull, larger is the area of representation. Now this lower limb part is near the center, is known by the term paracentral lobule. It's near the center, is known by the term paracentral lobule. Now we understand this paracentral lobule, the motor cortex, is the motor cortex for the lower limb. It is helpful for the movement of the lower limb. Okay. Now we understand, if at all there is a destructive lesion in the motor cortex at all, anytime if there is a destructive lesion in the motor cortex, that part of the brain won't work, that part of the body won't move. As a result, the patient will have paralysis, weakness. If at all we have got an irritative lesion, that is a brain tumor assist, something like this, irritative lesion, in that case seizure will occur. So if there is a destructive lesion in the brain, paralysis will occur. If there is an irritative lesion in the brain, seizure will occur. Okay. One easy one-liner on this, listen to me. If the patient is having Jacksonian march in the lower limb, where is the lesion? The lesion is in the paracentral lobule. Why? Lower limb motor cortex is this part. Seizure, irritative lesion. Jacksonian march, distal to proximal, proximal to distal. Okay. Second area we understand in discussion. Second area is micturition area. Micturition area, that gives me again that where should I micturate. I know when should I micturate, when the bladder is really full, I cannot hold the urine inside the bladder anymore. But as a milestone, till 3 to 4 years of a life, we understand that we have to micturate in the toilet. That is known as a bladder training. This thing, a micturition area, tells me to where to micturate. Micturition area tells me where to micturate. If I don't know where to micturate, I'll micturate anytime, any place when the bladder fills in. The word that you use is incontinence. Social incontinence would have been a better term. That loss of social inhibition on the bladder is known as social incontinence. So that is a term that we use for incontinence in this respect, a cortical lesion. So one liner question. Incontinence is a feature of which lobe? Frontal lobe. Frontal lobe lesion causes incontinence. Something to be more perfect here. This micturition area is located in the paracentral lobule. So that medialmost part of the lower limb wala, that is having the area also for the micturition cortex. So there is a micturition area in the paracentral lobule. Third area is supplementary motor area. Supplementary motor area, that is important for remission of primitive reflexes. So a child is born with certain reflexes which I know as sucking, grasping reflex. Those reflexes as the child grows up disappear. They disappear, primitive reflexes. So these primitive reflexes disappear with an effort made by the supplementary motor area. So lesion in the frontal lobe can cause primitive reflexes in old patient also. Okay, so frontal lobe lesion often present with primitive reflexes. Why? There is a supplementary motor area that is responsible for inhibiting the primitive reflexes. That is gone. Number 4, the very important one, Broca's area. B for Broca's, B for Bug, B for Bakwas. So whatever I do talking work, that is known as word formation. So the main function of the Broca's area is word formation. What I speak out, the word is formed in the brain, in the Broca's area, in the frontal lobe. One liner question. What is the location of this Broca's area? It is the inferior frontal gyrus. So the word formation is a function of Broca's area that is done by Broca's area, and the part of the brain that works for Broca's area is the inferior frontal gyrus. Okay. Number 5. Prefrontal area. Prefrontal area is very important for control of the emotions. All the emotions that we have, the anger, the happiness, anything, are formed in the limbic system. They are controlled by the frontal lobe. If the frontal lobe is not working well, what will happen? There will be no control on the emotions and we will have antisocial behavior. So one line of question again. Behavioral abnormalities signify a lesion in the brain. Which lobe? Frontal lobe. Because frontal lobe, prefrontal area, is concerned with control of the emotions. If the emotions are not controlled, patient will flow it out with lot of emotion, that will be known as an antisocial behavior. Okay. Then another lobe, parietal lobe. Parietal lobe is concerned with primary sensory cortex. Like there is a primary motor cortex in the frontal lobe, there is similarly a primary sensory cortex in the parietal lobe. This lobe of the brain is for localization of a particular stimulus. Like you have a mosquito bite on the foot, you scratch your foot. If you got a dandruff on your head, you'll scratch your head. Why? Because you get a pain on a skin receptor dermatome that travels up with the help of a spinothalamic tract. It ends at thalamus and is taken to the cortex to tell me where it is. So cortex has got one thing to do, localize wherever the stimulus comes in for. So like there is a motor cortex, there is also a sensory cortex alive in the parietal lobe that is very important for localization of a stimulus. If you have a problem, you will not be able to localize the stimulus. You will get the stimulus because taking it up is spinothalamic till thalamus. But the cortex is not intact. This time the patient is unable to judge where it is from. So loss of localization occurs in a parietal lobe lesion. Second function that they perform, parietal lobe, is stereognosis. Stereognosis is knowing the object on touch. Okay, the word for stereognosis means knowing the object on touch. A good example that we have from clinical practice, we give coin to the patient and make him touch the coin, and he'll palpate it is in the palm area and tell me what denomination the coin is, 1 rupee, 5 rupee, 10 rupee. Possibly 10 rupee will vanish off somewhere, he'll keep it to himself, 1 rupee he'll give it back to me. So we know on touch an object, that is known as stereognosis. Okay, so stereognosis is a function of parietal lobe. Number 3, interesting area, taste area. We eat a food, we know from which restaurant it is from, most likely. We keep on eating outside. But as a human being, we know we drink a black cold drink and we know it is a Diet Coke, not a Pepsi. We have a taste in ourselves, we get the taste, we keep the taste in the parietal lobe, in the taste area. Next time we get it, we recognize it. Okay. Now the word is geusia with reference to taste, and there is a problem in the taste that is known as dysgeusia. So there is a scientific term, medical term known as dysgeusia, ageusia, in which the patient is unable to identify the taste. Dysgeusia. Number 4, something from basic eye anatomy, optic radiation. We all know that there is an optic nerve that converges at an optic chiasma that diverges left and right into an optic radiation till the occipital lobe. The optic radiation happily pass through temporal and parietal lobes of the brain. Okay, so something goes wrong in the temporal and parietal lobe. There can be a damage to the optic radiation. There can be a field defect that we get known as scotoma. So scotomas are field effect that occur due to damage in the optic radiation, due to damage possibly in the temporal and parietal lobe of the brain. Number 5, the most interesting, angular gyrus. Angular gyrus has got one thing to do for me. It stores images associated with reading, with calculation, and with naming fingers. So you read the word on the display board, you read it via angular gyrus. You understand by Wernicke's, yeah, oh, that's different, but you read it, the word that is written in front of you, by angular gyrus, because since your childhood days you have a storage of A being A, B being B. So A and B all together you can read together, you can read it through angular gyrus. Calculation, a very simple thing that you do, 35 plus 43, you do it in the brain, calculation. You can see a finger, you can tell me what it is, thumb, index finger, middle finger, ring finger, little finger. You can identify your finger, name it properly, angular gyrus will help you for that. For a reference, if you read the alphabet this as B, okay, but if you read the alphabet B as this, what is this known as? A very famous term, learning disability known as dyslexia. One reason, because from your childhood days you never read the bed B as this, you always read the B as this. You have a difficulty in reading that is known as dysgraphia. Dysfunction in reading, dysgraphia. Difficulty in learning, dyslexia. I am adding the Greek term, dys means garbad, dysfunction in reading, graphia, in learning, lexia. Dysgraphia, dyslexia. Cannot do the calculation so properly, acalculia. Cannot identify the finger properly, finger agnosia. And in the patient, right to left confusion. They keep on bumping into things left and right, that is right to left confusion. So dysgraphia, dyslexia, acalculia, finger agnosia, and right to left confusion. Okay, these are 4 symptoms which fall under one roof, that is known as a Gerstmann syndrome. A very famous syndrome, Gerstmann syndrome. Right to left confusion means what? If I am sitting straight in a room and my door is on the right, I'll move on my right and move out from the door, but instead of moving from the right, I start moving towards the left. I have a right to left orientation problem. That is known as right to left confusion. So these people walk on the crowd, they keep on bumping left and right because they don't know what is right, what is left. This is known as Gerstmann syndrome. If you read Harrison clearly, Harrison mentions that left hemispherical lesion causes Gerstmann syndrome kind of a story. Okay, something to recollect: left hemisphere is with intellectual power and maths, right hemisphere is with music and arts. Intellectual power, acalculia, poor in maths. Okay, so Gerstmann syndrome is a constellation of these four symptoms, and it occurs very often in a left hemispherical injury. Now, another very important lobe for our life, that is temporal lobe. Temporal lobe has got one interesting area inside it, which is known as a primary auditory area. This primary auditory area is basically concerned with hearing. You hear a thing through the ear, first the external ear, then the middle ear, then the inner ear, and everything goes into the temporal lobe for hearing, primary auditory area. Now, if you cannot hear, that is known by the term deafness. Deafness, if I recall, has been divided in ENT book as conductive, middle ear, inner ear, eighth cranial nerve, sensorineural. But this is not the eighth cranial nerve, this is neither the middle ear, the problem is in the cortex. So we know it as a cortical deafness. So there is a term known as cortical deafness that occurs due to lesion in the temporal lobe. Number 2 area, Wernicke's area. Wernicke's area is for understanding a thing, that is known as comprehension. Okay. Wernicke's area is for understanding a thing, that is known as comprehension. Superior temporal gyrus is a part that is housing an area which is known as Wernicke's area, and it is for comprehension and for understanding a thing. Okay. So Wernicke's area is located in the temporal lobe. Number 3, a controversial thing slightly, area for olfaction. I claim it's controversial because some books mention that the olfactory area is in the frontal lobe. No, it goes into the frontal lobe olfactory nerve, and then the message goes to the temporal lobe. It is also in the frontal, it is also in the temporal, but more in the temporal. So olfactory area is located in the temporal lobe more. Okay, if you cannot smell, if you have a problem in smell, that is known by the term anosmia. Osmia term, which means relation to olfaction or smell. Means cannot smell. Number 4, optic radiation. Already I mentioned that optic nerve passes through that optic radiation till the occipital lobe. An optic radiation damage in the temporal and parietal lobe can result in scotoma. Okay. Number 5, the most important and the most interesting, deep oblique medial temporal lobe. Deep oblique medial temporal lobe. This part of the brain is basically concerned with a good thing, that is memory. Like, I work on a computer, but computer will save my work automatically. We have got an autosave. Sometimes I want to see that work done tomorrow. I'll put it in a hard disk. Good. But over a period of time, I may lose the hard disk due to certain corrupt virus, some problem. What do? I'll put everything that I have in a pen drive. Long-term memory. Hard disk, short-term memory. Autosave, immediate or working memory. So you keep on working with me, you keep on studying, you keep on remembering things, that is a working memory, immediate memory. If you can remember what I taught you last week, okay, that is short-term memory. Even if you remember things that I have taught you even after 10 years, that is a long-term memory. So everyone in the God grace has got a hard disk, has got a pen drive, and has got an autosave mode. Okay, like this. We have got a immediate and a short-term memory. We got an immediate and a short-term memory stored in the temporal lobe. It is converted to long-term memory in the hippocampus, and long-term memory is stored in a neocortex. Immediate and short-term memory is stored in the temporal lobe, converted to long-term in hippocampus, and that is further stored in a pen drive, that is neocortex. So that is the minimum and the maximum thing that you need to know about memory as a topic. That is the basic physiology that you need to know. Immediate short-term stored in the temporal lobe medial part, converted to long-term in hippocampus. Long-term is further stored in the neocortex. Okay. Now we have got a symptom of memory loss that is known as amnesia. If you remember it, amnesia. Someone meets with an head injury and loses the memory of the past. The past event that are lost is retrograde amnesia. But sometimes after the head injury, the patient doesn't register the day-to-day activities, what he had for breakfast, what he had for dinner, which doctor came and met him in the morning. He doesn't remember it. So he had a past intact memory, yes, but a very poor working memory after the head injury. So whatever the things that happen after the head injury, he doesn't store it in the brain. It is known as anterograde amnesia. So amnesia can go into two directions, the past memory retrograde and a new and onset or the fresh memory anterograde. A temporal lobe lesion typically produces an anterograde amnesia. Okay, you should know this fact. The temporal lobe lesion produces an anterograde amnesia. Why? Because immediate and short-term memory is stored in the temporal lobe. That's why. God's grace, God is great. We got two lobes of the brain. One is a dominant lobe and the second one is a non-dominant lobe. The word dominant and non-dominant came into the picture from physiology. They found that Wernicke's and Broca's area are not on both the sides of the brain. Wernicke's and Broca's area is only on one side of the brain, that is known as a dominant lobe. Wherever they are not seen, that is known as a non-dominant lobe. Okay. For a righty or a lefty, left hemisphere is always a dominant lobe, right hemisphere is always a non-dominant lobe. Dominant lobe left hemisphere is also known as categorical hemisphere. Non-dominant right hemisphere is known as a representative hemisphere. So categorical hemisphere and representative hemisphere, these are the two terms which are given for the right and the left hemisphere of the brain. Why I'm discussing it with amnesia, we'll understand if there is a left hemispherical dominant lobe or a categorical injury, patient faces an auditory amnesia. If it's a right hemispherical representative non-dominant lobe injury, patient faces a visual amnesia. I'll give you one reference for this. If you hear to my voice today and after a week you again hear to me and you don't remember whose voice is this, that is auditory amnesia. If you see me today and after 1 week again you see me and say who is he, that is visual amnesia. Cannot remember on seeing is visual, cannot remember on hearing is auditory. Okay. So these are the two things that you need to remember: auditory and visual, dominant and non-dominant, right and left hemisphere, categorical and representative. Now we'll discuss another easy topic that is known as aphasia. For assessing a patient with language or a speech disorder, you need to be very methodical in your approach. Like this way. We know that the patient will having two areas in the brain. One is a Wernicke's area and other one is a Broca's area. Wernicke's area is performing one good function for me, that is comprehension, and Broca's area is producing one good function, speaking or word formation. Okay. Wernicke's area, as we learned now, was in the temporal lobe and the Broca's area was in the frontal lobe. Actually it is temporo plus parietal, it is fronto plus parietal to be more exact. Something from anatomy book that it is not totally in the temporal lobe, it is in the temporoparietal lobe. It is totally not in the frontal lobe, it is in the frontoparietal lobe, more in the frontal lobe, less in the parietal lobe. Now what do we do for assessing a patient with aphasia is we tell him a command. We give him a command like this: show your tongue, raise your hand. So possibly a patient of mine will see me doing it or will hear me doing it, and if his Wernicke's area is perfect, he can understand what I am doing, understanding comprehension, then in that case he will follow my command. So I tell the patient, show your tongue, raise your hand, he listens, he understands, and he does it. If he doesn't listen, I show my tongue, raise my hand, he again understands and does it. So comprehension zone is well tested in a patient by asking him to follow a command, okay, by visual or maybe by auditory input. Second thing that you can do for the patient is you can see and show him an object and tell him to name it. What happens? You and me see an object, maybe we and me see a mobile phone. We understand it's a mobile phone and we answer correctly it's a mobile phone even from a distance. But this time what happened is a patient of mine could not understand what it is, a mobile phone. He just kept on seeing it and answered me it's a transistor. I asked him why transistor? He gave me a funny explanation. Walk while you talk is your motto on a mobile phone, walk while I hear is my motto on a transistor. So unfortunately he draws a simile between two box-like objects, mobile and a transistor, applied on the ear for a longer time required for hearing. Okay. Now the problem is this: patient cannot understand what it is. He cannot name it properly. He does understand it's for listening, but he doesn't know the name. Cannot name anomia. We had a different patient with us. We showed him a mobile phone and asked him what it is. He looked at it and said, it's a biscuit, I'm going to eat it now, give it to me. So that is even worse. Cannot even identify an object, cannot know the function, that is known as agnosia. So write it down. You tell the patient to see an object and name it. He names it well because his Wernicke's area is alright. But sometimes the Wernicke's area is not alright. He doesn't name it well, it is known as anomia. And he doesn't identify it well, that is known as agnosia. So agnosia is a term that means cannot identify. Cannot identify even the function. He sees a mobile phone, answer is that's a biscuit. It is totally absurd. He doesn't even identify the function of this object, that is known as agnosia. But if the patient sees a mobile phone, answer is that's a transistor. He knows the function but cannot name it. That is known as anomia. So we got two terms out of this, anomia and agnosia. Agnosia means cannot identify, doesn't know even the function. Anomia means knows the function, just cannot name it. Properly he cannot understand what it is. One case. Number 3. You tell the patient to repeat. Repetition. So patient of mine hears me. He understands me, one case. He makes a word through Broca's and speaks. That is a normal speech circuit. What happened? I told him 1, he understood 1, he made the word 1 and he spoke out 1. I told him 1, he understood 1 plus 1, 11 and he spoke well 11. So that is a problem. He could not understand what I am talking about. I am just saying the word 1. He is listening to me 1 plus 1, 11, 11. That's wrong. He doesn't understand. So difficulty in repetition again reflects a problem in understanding purpose, that is Wernicke's area. Number 4 is the speaking out on himself, that is known as a word fluency. Okay. So if the patient can form the word, he or she can talk properly, can form a word, can speak out fluently, fluency. So we understand that fluency, repetition, naming and comprehension, these are the 4 variables on which we see a patient with language or a speech disorder. For making it more practical, for making the thing more practical, what we'll do, we'll make a speech circuit, visual, auditory, goes into the Wernicke's, goes into Broca's, goes into the speech output. Wernicke's area is located in the temporal lobe. Broca's area is located in the frontal lobe. It's fronto plus parietal, it is temporo plus parietal. Temporo plus parietal, frontal plus parietal. For making the things more simpler, what we'll do, we'll draw a table. We'll draw a table with some 5 vertical columns. We'll draw a table with some 5 vertical columns. In which we'll pull the extreme left as aphasia, APH. Here we'll put it as COMPR, comprehension. Here we'll put it as REPT and repetition. Here we'll put it as naming. And the last thing that we'll put it as fluency. So comprehension, naming, repetition and fluency, these are the 4 variables on which we test any patient with aphasia or a language or a speech disorder. Okay. Now we already drawn a speech circuit. Visual, auditory input goes in for understanding, Wernicke's, and then goes in for word formation, Broca's, until we speak out well. We'll start with the Wernicke's aphasia first. Wernicke's is for understanding, comprehension. So what do? I tell a patient to show his tongue, raise his hand. He listens to me. He doesn't understand. He doesn't do. If he listens and understands, then only he does. Wernicke's area is for comprehension, for understanding. He doesn't understand. He doesn't follow my command. Comprehension minus absent. He listens to me 1. He doesn't understand 1. He doesn't speak out 1. Repetition absent. He sees a mobile phone. He doesn't understand it's a mobile phone. He doesn't repeat as a mobile phone. Naming absent. And the last but not the least is fluency. He doesn't understand what he is talking, so he talks a lot. Very often he keeps on talking a lot because his Broca's area is well functional in Wernicke's aphasia. What happens? The patient is talking a lot, he or she will have an explosive speech. They'll keep on talking, and they will have an explosive speech. They often have a speech which is often known as jargon speech, which is known as explosive speech. If they don't understand what they are talking about, they will form new words which have no meaning, known as neologism. Sometimes they make some words which have actually no meaning to anyone else. Because they don't understand what they are talking, they speak words which have no meaning, known as neologism. Second aphasia is Broca's aphasia. In Broca's aphasia, the Broca's area is not functional. The word fluency is decreased. Cannot form the words, cannot talk. He listens, he's basically sees a mobile phone, he understands a mobile phone. He tells me that is something for listening, but he doesn't make the word mobile phone, so he doesn't answer it as mobile phone. So naming again is improper. He, in Broca's aphasia, listens to be 1, he understands 1, but cannot make the word 1. So he or she cannot repeat, repetition absent. In Broca's aphasia, unfortunately, sometimes they understand what is going around. They listen to me, show your tongue, raise your hand, they listen, they understand, and they do it. They are able to do it because they understand it. Broca's area is not for making the command happen. It is for speaking it out, fluency. What happens in Broca's? They are able to understand because their Wernicke's is normal. So they understand, show your tongue, raise your hand, and in that sense they are able to do it. Broca's area, comprehension is well preserved. They understand the task and they perform it. I use the word unfortunate for one thing. They understand that they are not talking well. insight into the disorder is often preserved. As a result, they go into a bigger problem which is known as depression. They are unable to, if they are able to understand, they are unable to talk, they will often go into depression. This speech is not totally minus. They speak sometimes with a halt in between. That is known as a telegraphic speech. And number 4, they speak telegraphically, but when they sing, they are normal, melodic speech. They have got a singing which is normal. They are speaking telegraphically, but they are singing normally. So when they are speaking, they are telegraphic. They have a halt in between while they speak, but when they are singing, they are totally normal. The melody part is preserved, and they are able to sing normally. So that's a power of Broca's aphasia. Last but not the least, anomic aphasia. In anomic aphasia, the only thing that goes wrong is naming. Only thing that goes wrong is naming. Rest all is well. Only the naming part is at fault. Rest all is well. One easy question. Most common type of aphasia that we understand is anomic aphasia. The lesion for anomic aphasia is in angular gyrus. So most common type of aphasia that we understand is anomic aphasia, and the lesion for that is in the angular gyrus, not in the temporal lobe as mentioned by one of the guide. It is in the angular gyrus. Write down one question on this, one easy and one tough question. A patient being evaluated for aphasia in which I found that the repetition was absent, naming was absent, comprehension was absent, while the speech was effortless. Aphasia. Which aphasia? Wernicke's, Broca's, or anomic? 3 options. Wernicke's, Broca's, or anomic? Which aphasia? A patient being evaluated for aphasia is having repetition being abnormal, naming or comprehension abnormal, effortless speech. Simple. Wernicke's aphasia. Now the question that was actually asked in the Ames pattern was something different. Where is the lesion? I write it down. The lesion is in the dominant frontoparietal lobe. The lesion is in the dominant occipitoparietal lobe. The lesion is in dominant temporoparietal lobe, or the lesion is in non-dominant temporoparietal lobe. Okay, simple answer. Temporoparietal lobe is a lobe that houses the Wernicke's, and it has to be the dominant lobe that you are talking about if you are talking about a speech or a language disorder. Okay. Now one more question which is slightly difficult. Write it down. Damage to categorical hemisphere. Damage to categorical hemisphere leads to. Okay. Option A, normal speech. Option B, increased speech. Option C, decreased speech. Option D, senseless fluent speech. Damage to categorical hemisphere usually causes normal, increased, decreased speech, senseless fluid speech. There's a lot of opinion on this question. I'm very sure C and D. See, the examiner is very clever. The examiner is very clever. Actually, he mentions doesn't mention the Wernicke's and Broca's. He just mentions as categorical hemisphere. Categorical means a dominant lobe, left hemisphere. He doesn't mention Wernicke's and Broca's. I'll give you a sense of this. Normal speech, absolutely never. Normal speech is not possible. Increased speech, I'm speaking more, doesn't mean I have aphasia. Decreased speech, you are seeking less, doesn't mean you have aphasia. The problem is that the word that the examiner has used is increase and decrease speech, which are layman terms. That doesn't mean aphasia anytime. What is aphasia? Senseless, fluent speech. That is more in favor of Wernicke's. See, the examiner is not very clear. He is asking Wernicke's or Broca's, because decreased speech doesn't mean telegraphic speech. Telegraphic speech would have been a different thing. He is mentioning decreased speech. Someone in depression doesn't speak more. Someone in anxiety speaks more. So it doesn't mean aphasia is a problem with them. Senseless fluent speech is more scientific a term. Okay, more in relation with the Wernicke's. So I'll go with not the correct but the most appropriate answer. I'll go with D. Okay. For one reason, it is more in form of a Wernicke's. Transcortical aphasia or aphasia in which the repetition part is preserved. Okay. So sometimes in Wernicke's and Broca's aphasia, if the repetition part is preserved, rest everything remains the same, is known as transcortical aphasia. Global means everything gone, everything, all four parameters gone means global. Now we'll discuss like this, which artery supplies which part of the brain and what can be the neurological deficit. We'll start with the anterior cerebral artery or ACA. Anterior cerebral artery, the word comes anterior for one reason, it supplies the anterior half of the brain. It supplies the frontal lobe. It doesn't supply the complete frontal lobe, it supplies a part. It supplies the medialmost part, paracentral lobule. It supplies the paracentral lobule. Paracentral lobule is a lobule that manages the lower limb. So if something goes wrong in the paracentral lobule, lower limb weakness. Something goes wrong in the paracentral lobule, incontinence. Second area, supplementary motor area. Supplementary motor area is for maintenance of primitive reflexes. So if the supplementary motor area is lost, we will have the primitive reflexes coming back to life. And last but not the least is the prefrontal area. Prefrontal area is basically concerned with control of the emotions. If the emotions are not well controlled, patient of mind will have an antisocial behavior. So if a patient comes to me with behavioral abnormality, that is also a stroke. The lesion is in the frontal lobe, but to be more precise now, it is a lesion in the anterior cerebral artery. Incontinence, loss of social inhibition, frontal lobe, which artery? ACA. Resurgence of primitive reflexes, again ACA, frontal lobe lesion. Now we'll draw the diagram again for our own interest, that the motor cortex diagram again, Brodmann's area. This is the lower limb, medialmost part, the trunk, arm, forearm, the hand, the face. We understand that the medialmost part, the paracentral lobule, is supplied by anterior cerebral artery or ACA. Rest of the motor cortex is routinely supplied by middle cerebral artery or MCA. One easy question that we often face in the MCQ is this: hemiparesis occurs due to lesion in. See, hemiparesis means weakness in the upper limb is much more than the lower limb. A face is deviated, the hand is flickering 1/5, but the lower limb is still moving 4/5 power, and the patient is walking with that particular circumduction gait. So in the patient with stroke, we get a problem in which the upper limb is more profoundly weak than the lower limb. Why? Because an MCA territory involves the upper limb and the face badly, but around that MCA territory, in fact, you'll have edema. Edema will kill the lower limb less. Infarct will kill the upper limb more. So weakness in the upper limb more than the lower limb is known as hemiparesis. It often occurs when the lesion is centered at the level of MCA. So MCA territory infarct can cause hemiparesis. One more thing, when the fibers that come down descending track, they are also known as corticospinal tract or pyramidal tract. They all come down and converge at a point which is known as internal capsule. Internal capsule is a subcortical structure where all the corticospinal or the pyramidal tracts are sitting down. Someone here, a lesion here, which is small anatomically, which will be always small radiologically, will cause a problem neurologically big. So we have got a patient with a small lesion and a large deficit. We got a patient with a small lesion and a large deficit due to lesion in the internal capsule. This kind of a problem is known in the book as dense hemiparesis. So the word dense is mentioning the word density of the fibers, more there. Hemiparesis, one side of the body getting paralyzed. So the word that we use is dense hemiparesis. Small lesion, large deficit. Now what happens is this posterior limb of internal capsule is supplied by MCA, middle cerebral artery. So that has been a routine question in the Ames pattern. The dense hemiparesis occurs due to lesion in internal capsule, which artery? Middle cerebral artery. One more question that we faced in the one-liner pattern this season was this. Pure motor hemiparesis. Only motor fibers are involved. That is pure motor hemiparesis. That is again the word dense hemiparesis. It occurs due to lesion in internal capsule in middle cerebral artery. Okay. One question more. Aphasia occurs due to lesion in which artery? Aphasia. Aphasia usually occurs due to lesion in middle cerebral artery or MCA. For one reason, Wernicke's and Broca's area is supplied by middle cerebral artery. Okay. One-liner question again. Amnesia occurs due to lesion in which artery? Forgetfulness or amnesia occurs due to lesion in which artery? It often occurs due to lesion in posterior cerebral artery. We found this question written in names like this. Medial temporal lobe and hippocampus is supplied by posterior cerebral artery. Okay, that can cause amnesia. Wernicke's and Broca's area is supplied by MCA, that will cause aphasia. Pure motor stroke, pure motor hemiparesis, dense hemiparesis, small lesion, large deficit, internal capsule, MCA. Just the word MCA, hemiparesis, weakness more often in the upper limb, lower limb, hemiparesis, MCA. So amnesia occurs due to lesion in PCA. One more question that we found in the Ames pattern this season was this. Gait apraxia. See, the word apraxia means cannot move. You walk, you move with your lower limb. Who is supplying the lower limb? Paracentral lobule. Who is supplying the paracentral lobule? ACA territory. So there is a lesion in the ACA territory. What will happen? The patient will not be able to move the lower limb at all. Not even that circumduction gait is possible. Patient is unable to move around. Gait apraxia occurs due to lesion in ACA. Now a brief treatment outline. How do you treat a patient of stroke? I'll start with the ischemic stroke. Infarct, ischemic stroke. Number one, you could easily thrombolize the patient. The thrombolysis agent of choice is recombinant tissue plasminogen activator, RTPA. Recombinant tissue plasminogen activator is the thrombolytic agent of choice. It is given at a dose of 0.9 mg per kilogram of body weight. So that's the dose of the recombinant TPA molecule that is given for thrombolysis in a patient of ischemic stroke. Now there's a lot of controversy on this, a window period. The time from the onset on which you get to the patient to the hospital, window period. From the onset till what time can you give this drug, thrombolytic agent? Previous editions of Harrison. Previous editions of Harrison mentioned it as 3 hours. Recent edition mentions it at 3 hours and 4.5 hours, but something as a consensus in India population, it is 4.5 hours. So from the onset till 4.5 hours, if you get the patient into your hospital and you diagnose him or her with a stroke which is ischemic, you can use this thrombolytic agent. So from the onset, now it is 4.5 hours. Somewhere in radiology, sir might teach you that sometimes in a patient with stroke, if you find a diffusion weighted MRI defect, even at 6 hours you can thrombolize. But for all practical purposes, we understand that it is 4.5 hours, not 6 hours. 6 hours on radiological basis, but more appropriate nowadays is 4.5 hours, safe and better approach. What else can you give to the patient? Apart from the thrombolytic agent, we can use certain drugs which will prevent the aggregation of platelets and prevent the further clot progression, antiplatelets. The antiplatelet of choice is aspirin. Aspirin is given at a dose minimum as 50 milligram and maximum as 325 milligram per day. Please remember this. You use clopidogrel very often? No. Clopidogrel is not for the heart, it's only for the heart, not for the brain. It is only an aspirin tablet that needs to be given to the patient. Number 3. Number 3 is anticoagulant. Anticoagulants are drugs which will inhibit the clot formation. The word is anticoagulation. For example, we have got in the hospital stay being given to the patient heparin, and when the patient goes home, he goes home on a tablet of warfarin. Anticoagulant will inhibit the coagulation, will inhibit a clot formation in a circumstances when the patient is having atrial fibrillation. One direct indication, because in AF patient what happens is 4 chambers of the heart, the left atria pumps at a higher rate. It keeps on pumping at a higher rate and it dilates the atria. Atria dilatation can produce a clot somewhere in the appendage. That clot can easily go into the circulation and cause an embolic stroke. So we know that if the patient is having atrial fibrillation, in a routine practice also, we give an anticoagulant just to prevent the formation of a stroke. Second anticoagulant indication that we found in the book was prosthetic wall. We give a artificial wall to the patient, maybe a mitral wall, aortic wall. These are artificial walls. Post-operatively, you always anticoagulate the patient because on that prosthetic wall, there are high chances of clot formation and that clot can easily go into the circulation of the brain and can cause a stroke. So routine practice also, we anticoagulate any patient who is on a prosthetic artificial wall or a patient who is having atrial fibrillation. Write down this question. You'll understand what I'm talking about. A recent question in AIMS. A 60-year-old male with history of native aortic valve disease had hemiparesis 1 week back, which is improving. ECG is within normal limit. Now the treatment. Option A, thrombolysis. Option B, aspirin. Option B, warfarin. Option D, B plus C, that is aspirin with warfarin. Only few centers have answered it correctly. Actually, I'm surprised. Um, See, what do we understand as a native aortic wall disease? Native means original, indigenous. At an age of 60 years, someone can have a calcified aortic wall, can have aortic stenosis. Yes, fine. He has got aortic stenosis and he has got hemiparesis 1 week back, which is improving. What would have happened? Aortic stenosis would have impaired the blood flow to the brain, would have taken a clot above, and would have caused something problem. Now in clinical practice, we get a patient, listen to this Panda, we get a patient who comes with a weakness, hemiparesis, and I see the power on admission. Power on admission of the limb is 1 by 5. He stays maybe in the ward for 1 week and it becomes 4 by 5. Or it happens that sometimes he comes with 4 by 5, goes home with a power of 1 by 5. So there is a difference now. A person who improves is 1 by 5 to 4 by 5 power is an embolic stroke. A person who is having 4 by 5 to 1 by 5 is a thrombotic stroke. So in an era when we did not have a CT MRI, we could again imagine a patient who was improving was most likely an embolic stroke. A person who was deteriorating was a thrombotic stroke. We get a sense. So now we have a patient with has a weakness 1 week back which is improving. Most likely he has got an embolic stroke and he has got an aortic stenosis. He doesn't have an artificial aortic wall. The word native means non-artificial, original. Okay. And he has got a ECG that is normal. In the patient, what do I don't have? I don't have a prosthetic wall. I don't have a atrial fibrillation. So now what should be the answer? Simple. Aspirin, or still you are sticking to warfarin? Tell me now. Aspirin or still warfarin? Whatever I have told you is all scientifically done. You cannot give warfarin for every embolic stroke. You give it for a particular situation. When you have got AF, when you have got a prosthetic wall, both of the things are not seen in the patient. Don't jump to give warfarin. Simple answer, antiplatelet, aspirin to the patient. Thrombolysis is out of question, one thing I am very sure of. Don't give a plus to this. See, I used to always imagine every embolic stroke should get a warfarin. No. There is a clear-cut indication, AF and IF and prosthetic wall. Only two indications are giving an anticoagulant. Otherwise, you just wait and watch. Okay? So, simple answer made by AIMS. See, names, they don't ask you the diagnosis. They ask you, see the one step ahead, the treatment. So, in this question, you should know how is the patient having, what is he having, what are the indications using warfarin and all. Okay. Dose of aspirin in clinical practice is never 50 milligram. It is usually 150 milligram per day. 325 milligram is very high dose. We maintain it between 75 to 150 milligram per day. Okay. Sure. Now we'll try to discuss the hemorrhagic stroke. Hemorrhagic stroke. Firstly, we'll classify the hemorrhagic stroke. If you see the skull, within the skull you see the brain. Within the brain you get an hemorrhage. It is known as intracerebral or intraparenchymal hemorrhage, ICH. Sometimes you see the hemorrhage between the parenchyma and the skull, that is known as extracerebral, extraparenchymal, extraaxial hemorrhage, like this. Extracerebral hemorrhage are divided into three anatomic types. If you remember something from anatomy and radiology, that there are three layers covering the brain from inside to outside, three meninges: pia mater, arachnoid matter and dura mater. Between pia mater and arachnoid matter, it is subarachnoid hemorrhage. Between dura mater and arachnoid matter, it is subdural hemorrhage. Between the skull and the dura mater, it is extradural hemorrhage. So there are three layers, meninges, and these are three pattern atmosphere of how we arrange the extracerebral hemorrhage. Now common MCQs that we get, easy MCQs that we get. Most common type of hemorrhagic stroke is always a intracerebral hemorrhage or ICH. Out of ECH and ICH are always more common. One more MCQ. Most common cause of ICH. A very easy one-liner question that we get, hypertension. Most common cause of intracerebral hemorrhage is hypertension. Most common type of hemorrhagic stroke is ICH. Now what are the sites? Another MCQ that we often get. If you see the hypertensive intracellular bleed, what are the sites? Number one site is basal ganglia. One MCQ, easy one. Most common site of hypertensive intracellular bleed is basal ganglia. Sometimes you don't mention the word basal ganglia, they might mention a tenant of basal ganglia, that is putamen. Like caudate nucleus was chorea, that was also basal ganglia. This time putamen is basal ganglia, a site for hypertensive intracellular bleed. Basal ganglia I mentioned was a secretory of the cortex. So someone goes wrong in the secretory, no message will be conveyed to the body. Patient will have hemiparesis. So very often in clinical practice we get patients of hemiparesis with a high blood pressure. The most likely site is basal ganglia. Number two site is thalamus. As I mentioned in quick words, that thalamus is an organ that is a sensory organ. So whatever sensation is brought under the skin, pain, temperature, touch, goes up through a tract spinothalamic. It always ends at thalamus. So a thalamic injury will impair the sensation on one side of the body. That is known by the term hemianesthesia. So hemianesthesia means a loss of sensation on one side of the body due to lesion in the thalamus. Number 3. A balancing organ in my body which I recall as cerebellum. If cerebellum is lost, the balance of the body is not very proper. As a result, the patient will have ataxia and the patient might have also vertigo. So ataxia and vertigo are symptoms which occur in a cerebellar bleed. Number 4. The most catastrophic of all is always a pons. Why? If you remember from basic physiology and anatomy, pons and medulla oblongata are areas in which all autonomic, cardiac and respiratory centers are located. So in a pontine injury, what do I get? I get tachycardia, increase in heart rate. I get tachypnea, increase in respiratory rate. I get hyperthermia, increase in temperature. And I get hyperhidrosis, which means increase in sweating. Everything said and done, pontine hemorrhage, everything will come up. Something which will come down is a pupillary spice, which is known as a pinpoint pupil. Something of clinical relevance. These pinpoint pupil occur in two more situations. One is organophosphorus poisoning and the second is morphine ingestion. So pinpoint pupils you can get in OP poisoning and morphine ingestion. One thing extra that was asked in AIIMS this season was in a pontine hemorrhage, what do you characteristically get? Apart from this is bilateral extensor plantar. Bilateral extensor plantar is something suggestive of pontine hemorrhage very often. Now one easy MCQ, one liner. Hemorrhage with the worst prognosis is pontine hemorrhage. As you can see from all the things that I have talked about, pontine hemorrhage, the patient will die, worst prognosis. Cerebellar bleed, something important. Only in a cerebellar bleed you have a treatment. What? Removing the blood, decompression. So removing the blood from the brain is done for a cerebellar bleed. Okay. So decompression and removal of the blood only for a cerebellar bleed. Like when I was an intern, I used to see patients in my ward with a BP of 240/120. I used to see basal ganglia bleed and in a hurry I used to send the neurosurgical reference. Neurosurgeon used to come back and tell me, maintain BP, maintain hydration, maintain ICT, no need for surgery. See, basal ganglia, thalamic, pontine hemorrhage are too deep inside. You cannot approach it even with a craniotomy technique. Only one which is superficial is cerebellum, posterior fossa. You easily approach it, take it out, and a benefit for the patient. So decompression, that is removal of the blood from the skull, is done only for a cerebellar bleed. Very important statement. Now one more topic related or cousin of ICH, that is ECH, and a very important topic in that is subarachnoid hemorrhage, SAH. We'll start from the very basic thing. We've got a subarachnoid space with us. A subarachnoid space is containing something with it, that is a network of the vessel at the base of the brain known as a circle of Willis. Along with it, it is also having a CSF. One easy question, CSF is formed in, we all know this, it is formed in the choroid plexus. Where is it absorbed? It is actually absorbed in the arachnoid villi. So between the pia mater and arachnoid mater, the CSF comes in and it is directly absorbed into the arachnoid villi. And in the subarachnoid space, we have also got the network of the vessel round in a circular manner at the base, that is known as circle of Willis. Now I'll tell you the funda behind this, because wherever the two vessels join each other at the point of union in the circle of Willis, there is an outpouching that is seen. This outpouching is not beaded, it is round. It is known as saccular. It looks like a berry fruit hanging from the tree. That is known as saccular or berry aneurysm. A rupture of this aneurysm releases the blood in the subarachnoid space, causing subarachnoid hemorrhage. Etiology. If I look at the topic subarachnoid hemorrhage, what are the causes? Number one cause is trauma. And number two cause is rupture of saccular berry aneurysm. One easy MCQ. Most common cause of subarachnoid hemorrhage is always trauma. Okay. Most common cause of spontaneous subarachnoid hemorrhage is berry aneurysm rupture. The word spontaneous actually means non-traumatic. Don't think spontaneous is all of a sudden. Even a trauma is all of a sudden. But the word spontaneous in pathology book means non-traumatic. So I'll go with the word like this. Now one more question from pathology section, old question from AIMS. Where the vessels meet at the point of union, which layer of the vessel wall is weak to cause an aneurysm? To cause an aneurysm, we found that the defect is often seen in muscular layer or tunica media. So that's an old controversial question of AIMS again. That which vessel wall is weak at the point of union of the two vessels in the circle of Willis to cause an aneurysm? It is tunica media. See, there are two options, intima and media. In Harrison, he has confused this thing a lot, but I have cross-checked in all the pathology and neurosurgery book. It is most of the time media. Okay, so it is not the intima, it is the media defect that causes, enlarges, becomes an aneurysm. Somewhere like this, you can look into the diagram again. Two vessels happily unite with each other, no problem, normal. Suddenly there is a defect at the point of union in tunica media. Due to heavy flow across that defect, it enlarges, becomes an aneurysm. Further flow, aneurysm ruptures, becomes a subarachnoid hemorrhage. This is the story of an aneurysm leading on to SAH. Now the thing is that it's a gift from the God that the aneurysm only appear at the base of the brain in that circle of Willis. So you'll understand the diagram of circle of Willis again to make the concept more clear. I look at the base of the brain and draw the circle of Willis. Common carotid, I remember, in the neck at the upper border of thyroid cartilage, it bifurcates into external carotid that goes outside the skull, temporal artery, and one artery goes within the base of the brain to become internal carotid. Now from both the sides, internal carotid come to the base of the brain. Internal carotid artery, ICA. It comes to the base of the brain and it happily bifurcates. This time it bifurcates into anterior cerebral artery and middle cerebral artery, MCA. So ICA bifurcates in the anterior circulation into anterior and middle cerebral artery. Middle cerebral artery further bifurcates itself into superior and inferior division like this. From the back, I believe, two vertebral arteries join together to form a basilar artery. which bifurcates into left and right as the posterior cerebral artery or PCA. Anterior and the posterior circulation happily join each other with the help of a posterior communicating artery. The left and the right on the interior circulation join each other with the help of an interior communicating artery. Okay. So that's a very interesting diagram of circle of Willis that we know. Where the two vessels unite at the base of the brain in the circle of Willis, there is a defect in the tunica media that happily enlarges, becomes a sacral or aneurysm. Further it ruptures, causing subarachnoid hemorrhage. So in the diagram itself you can mark these are the possible sites of aneurysm that you possibly see. One question that we get very often, most common site of aneurysm to appear and the least common site of aneurysm. Two sites, least common site and the most common site. You can easily make it in the diagram. ACA and anterior communicating artery junction is the most common site. Vertebro-basilar junction is the least common site of aneurysm to ever appear. So this is the most common site, this is the least common site. Now we understand that aneurysm appear, yes, but they see in the diagram that anterior circulation aneurysm are more common as compared to the posterior circulation. Okay, so anterior circulation aneurysm are more common, posterior circulation aneurysm are less common. Chalo, I'll make you a question, make you do this question now. Write it down. Aneurysm is least likely seen in which artery? I'll give you option: posterior communicating artery, PCA, basilar, vertebral. In which artery the aneurysm is least likely to appear? Posterior communicating artery, PCA, basilar or vertebral? Chalo, rhythm correct. I'm happy with that because you understood my point. Anterior circulation aneurysm more common, posterior circulation aneurysm less common. So if you lead in the diagram, vertebral artery is the posterior most artery. So that the artery in which the aneurysm is least likely to appear. So this is an indirect question that we got in AIIMS, one-liner question. Okay. Now what happens is that in this drama, sometimes one cranial nerve can get involved. One cranial nerve, that is a third cranial nerve. You see the diagram of the third cranial nerve again like this. It often runs around that posterior communicating and ICA junction and it runs over the PCA. So there is a cranial nerve that is the third or the oculomotor nerve that is most commonly involved in an aneurysm ever. So let's solve this controversial question again. Most common cranial nerve. Most common cranial nerve involved in an aneurysm is third. Involved in raised ICT is sixth. More topics to follow. Guillain-Barré syndrome, it is seventh. Diabetes, again controversial, it is third. One question that I got from anatomy: longest intracranial course. Tell me this one. Longest intracranial course of which cranial nerve? Third, fifth, seventh or fourth? Fine, good. Rhythm correct, fourth. Not the sixth. See, it's wrongly given in one of the guide as sixth, it's the fourth. One easy question again. Most common cranial nerve to get paralyzed. Fifth, seventh, third or sixth? Okay, rhythm correct again, I am very sure seventh. Because the seventh cranial nerve often passes through that middle ear, stylomastoid foramen. Something funny happens there, will paralyze the cranial nerve. Seventh cranial nerve is the most common to get paralyzed. Okay. Now we'll see the clinical manifestation or clinical features of subarachnoid hemorrhage. One of the features that the patient has is immediate. And the headache that the patient comes to me is a very typical kind of headache, which I know as the word thunderclap headache. Thunderclap headache. What is this? Look into this diagram. Fortunately, the subarachnoid space is not only around the cortex, it is also around the spinal cord. That's why for taking out the CSF, you do a lumbar puncture, because subarachnoid space is continuous network from the cortex, around the spinal cord even, between the pia mater and arachnoid matter. Now what happens, our patient has got one aneurysm and it ruptures. It brings around 100 ml of blood, but the blood flows along with the CSF in the subarachnoid space. Very important, because in the subarachnoid space we have got the circular villus, aneurysm, and also the CSF along with it. And we know from physiology that CSF revolves around 5 times in a day up and down like this. So what happens is, wherever the aneurysm rupture, patient feels as if an electric current has fallen onto his head. Not the electric current, a thunderbolt has fallen onto his head. As the rupture occurs, he feels that, and as the blood moves down with the CSF column, he feels that the electric bolt has gone down. And after some days he comes to me and tells me that this electric current is still passing through him. Why? Because the blood is still moving around with the CSF in the subarachnoid space. The typical variety of headache that the patient claims is like this. The headache is maximum at the onset and possibly dies down sharply, as if electric current or some thunderbolt has fallen onto his head, has gone down being earthed. So this is a very typical variety of headache that we know as thunderclap headache. It is a collection of the blood around the meninges. As a result, meningeal irritation will occur and the patient of mine will have neck rigidity. Because of raised ICT, very often the patient will have loss of consciousness, but not for a very long time. It's often a transient loss of consciousness. But the important finding that we see is that the blood doesn't stay static at one point. It keeps on moving along with the CSF at every point. So it cannot exert an effect on a cortex. It doesn't affect the basal ganglia even. So something, there's a drama which we saw in a patient with ICH was hemiparesis, hemianesthesia, hypertension, tachypnea, and all these things are not seen. So in these patients of subarachnoid hemorrhage, very importantly, we don't have a focal neurological deficit. So focal neurological deficit is not seen in the patient, a very important statement, at the onset of aneurysm rupture or subarachnoid hemorrhage. Write down a question at this point, an interesting question that we often get in AIIMS every 6 months. Write it down. Don't have space, I'll write it on a different page. A 45-year-old hypertensive, male is brought in casualty with history of severe headache, nausea, vomiting for 2 hours. On examination, neck stiffness is present in the patient. Ptosis is also present in the patient. Rest of the examination is within normal limit. Diagnosis: number 1, hypertensive ICH. Number 2, migraine. Option C, arteriovenous malformation. Option D, aneurysmal subarachnoid hemorrhage. A 45-year-old hypertensive male patient is brought with a history of nausea, vomiting, headache, neck stiffness for 2 hours. Ptosis, rest of the examination is normal. What is the diagnosis? Rhythm correct again, aneurysmal SAH, I am very sure. Tell me one thing. Would it not be in hypertensive ICH? He's an hypertensive male, no? Why not hypertensive intracerebral bleed? Why not hypertensive intracerebral bleed? Oh, ptosis, non-specific. Neck stiffness, again non-specific. I'll tell you, if the basal ganglia bleed, very often in clinical practice you might see the blood moving into the ventricle. If it moves into the ventricle, it can cause neck stiffness. And the answer is this: no other finding, no focal neurological deficit. That is not ICH, that is SAH. A patient of ICH will also have something: severe headache, nausea, vomiting, even loss of consciousness. And this time the patient gets up, he or she gets up with hemiparesis. That is ICH. If the patient gets up normal, that is SAH. Okay. Now we will consider the discussion on other features of SAH, clinical features. One type of clinical feature that we get is delayed. After the SAH has happened, we start getting it delayed. Number one is vasospasm. In vasospasm, what happens is that there is a vessel that is communicating the blood to the brain. Suddenly around that vessel some blood accumulates in subarachnoid space. That was SAH. But this blood is flowing with the CSF only for 3 days. Because on day 4, day 5, I believe the coagulation cascade will make the blood sit at one spot, clot formation. If a clot formation occurs in the subarachnoid space around the vessel in the circle of Willis, what will happen? It will compress the vessel from outside and it will impair the flow any further from this point to this point. So what happens? I have a patient of subarachnoid hemorrhage today. I repeat a CT, I repeat an MRI after 4 days and I found an infarct. This is ischemia. This ischemia is neither embolic, neither thrombotic. It is because the vessel is getting from blood pigments compressed from outside. Vasospasm. Such a kind of drama that you can possibly see doesn't happen on day 1 of SAH. It usually occurs 3 to 21 days after the subarachnoid hemorrhage has actually occurred. So when the patient has suffered with subarachnoid hemorrhage, maybe after 3 to 21 days you can have a vasospasm kind of a story. See, a patient of SAH doesn't have hemiparesis. If he or she develops hemiparesis, it is not due to ICH directly, it is indirectly due to this vasospasm. Number 2, re-rupture. What happened, God's grace, we had an aneurysm, it ruptured. After some time, coagulation cascade was sealing that puncture site and the aneurysm was stopped bleeding. But if you don't diagnose the aneurysm on time and you don't treat it on time, it may again rupture. Re-rupture is a story. That doesn't happen immediately. It occurs some days later. Re-rupture, delayed deficit. Number 3, hydrocephalus. Hydrocephalus is actually a term that is a radiological term. Cephalus brain, hydro water. We see the ventricles of the brain getting dilated. Why? Because one of the very famous cause of raised ICT that you learn in day in day out in physiology classes is decreased CSF absorption. More CSF formation, hardly any disorder I know 100 disorders which have got the same problem, decreased CSF absorption. So what happens? CSF is absorbed less. Why? Because the CSF is absorbed in the arachnoid villi. That arachnoid villi is clotted with blood. So blood delays the absorption of CSF, decreased CSF absorption. As a result, the CSF will remain in the part more often seen, ventricle, and the ventricle will get dilated. That I know as the word as hydrocephalus. So the blood sits down and blocks the arachnoid villi and it decreases the CSF absorption. As a result, the CSF sits down in the ventricle and it dilates, hydrocephalus. Number 4, the most tricky, hyponatremia. Why? Because in raised ICT environment, they claim and write in the book that 2 molecules often come out. One is ANP and other one is BNP. Atrial natriuretic peptide, brain natriuretic peptide. The word is uretic and the word is natri. So we get natriuresis. Natri means sodium. Uretic means urine. So what happens is natriuresis occurs in the patient. As a result, there is a loss of sodium in the urine, and the sodium loss is from the body. So there is less of sodium in the body due to natriuresis. I believe something from biochemistry you might know. If the sodium moves along, it also pulls along the water. It is hypertonic. So you lose the sodium, you lose the water, and the word is hypovolemic hyponatremia. The term that we use very often to describe this kind of a drama is cerebral salt wasting disease. Disease atras a problem waste out of the salt, the sodium, due to problem in the brain, cerebral. So the word that we should know is the word cerebral salt wasting disease, which is hyponatremia, which is often hypovolemic hyponatremia. Okay. Now remember this way: V for villain, V for vasospasm. Why? Because in the book they write like this: most common cause of morbidity and mortality. Morbidity and mortality in a patient with subarachnoid hemorrhage is always vasospasm. So a patient of mine dying, that is mortality. A patient of mine having hemiparesis, that is morbidity, is always vasospasm. So vasospasm happens to be the most common cause of morbidity and mortality in a patient with subarachnoid hemorrhage, not hydrocephalus. I want to tell this point because in one of the guide I read hydrocephalus. No, it's a line in Harrison very clearly. Most common or very common cause of mortality and morbidity in patient with SAH is vasospasm. V for villain, V for vasospasm. Investigation. See, something from radiology, if you remember, if you want to see blood in the brain, you rely on a CT scan. If you want to see ischemia and infarct in the brain, you rely on MRI. So I want to decide investigation of choice, IOC. If I want to see the hemorrhage, subarachnoid hemorrhage, then I want to see the blood in the brain. For that I only do a CT scan, that is a non-contrast CT scan of the brain. With a contrast for a seizure protocol, without a contrast for a stroke protocol. Now investigation of choice for looking into the aneurysm would be angiography. Why? Because I need to visualize that circle of Willis at the base of the brain. It's a very easy thing, not a very easy thing to be done, but for radiologists very typical, because that circle of Willis occur at the base of the brain. So you need to focus the base of the brain with all the vessel being glorified there, angiography. So 2 questions and 2 answers. Don't mix up the 2 things. I've seen student answering like investigation of choice for SH, angiography. Baba, angiography will only tell me is there an aneurysm or not. It will never tell me it is SH or not. For looking at the SAH, I need to do a NCCT brain of the brain. Now, we should know one thing, memory based, that for grading a patient with subarachnoid hemorrhage, like you grade a patient with head injury with a Glasgow Coma Scale, GCS, very often you use it in your ward and clinical practice. But for grading a patient with subarachnoid hemorrhage, we require a scale that is known as Hunt and Hess scale. So there is a scaling system which is known as Hunt and Hess scale that is done for grading a patient with subarachnoid hemorrhage. Hunt and Hess scale. Treatment. One treatment, that is surgical treatment. What do you see? You see an aneurysm. What you can possibly do as a clever method, you can put a clip at the base of the aneurysm and stop the flow into the aneurysm. Get rid of the aneurysm, get rid of SH. So the SH happens because of the flow into the aneurysm. You stop the flow by putting the clip at the base of the aneurysm. But nowadays more technical things are coming up in the market. Angiography. When you do a cerebral angiography, you see the aneurysm. At that very point you put a coil inside it so that no blood comes into that aneurysm, no rupture of aneurysm is possible. That is known as coiling. So clipping and coiling are the 2 surgical procedures that you follow. Second one, more importantly and earlier followed, is a medical treatment. Why medical? To save the patient's life. V for villain, V for vasospasm. Now one drug that really works very well is nimodipine. Nimodipine is intracerebral calcium channel blocker. If you remember, calcium channel blocker are vasodilators, and the action this time is intracerebral. It will not dilate the vessels of the heart, it will not dilate the vessels of the limb, it will dilate only the vessels of the brain. Intracerebrally acting calcium channel blocker, nimodipine. It inhibits the vasospasm. So what was vasospasm doing? Someone is pushing the vessel from outside. I'll dilate it from inside by giving one drug, nimodipine. So one easy question, drug of choice for SAH, nimodipine, if someone asks you that. Now there is a therapy that we follow that you need to be aware, that was asked in this season, or it was triple H therapy. Triple H therapy, 3H. What are the 3H? Hypertension, hypervolemia, and hemodilution. Hypertension, hypervolemia, and hemodilution. What is the funda behind this? It's all physics. If someone is trying to push the vessel from outside, that was vasospasm. I'll try to dilate the vessel from inside by giving one drug, nimodipine, one possibility. Secondly, by giving more pressure on the vessel wall by hypertension. Hypertension exerts more pressure on the vessel wall. So I can oppose this vasospasm by applying more pressure from inside to outside by hypertension, by increasing the blood pressure. You don't increase the blood pressure by giving inotropic agent. You give more fluid, hypervolemia. And it is a benefit for me. Why? Because one day my patient will have hypovolemic hyponatremia, cerebral salt wasting disease. So give more fluid, benefit for me. You give fluid not by oral intake, you give it intravenously. The word is hemodilution. So that's a thing that we know as triple H therapy. Maintaining a high BP by a high amount of fluid given intravenously for a patient with subarachnoid hemorrhage, triple H therapy. Just to prevent the morbidity and mortality in the patient, vasospasm. Now two cousin brothers of subarachnoid hemorrhage that you might be reading again in your radiology classes, subdural hematoma and extradural hematoma. Studying it separate will make it difficult. We'll discuss it in a tabular form. Difference between subdural and extradural hematoma, SDH and EDH. Subdural hematoma often occurs due to rupture of cortical bridging veins. Okay. Extradural hematoma occurs due to rupture of middle meningeal artery, MMA. So don't make it as MCA, middle cerebral, no, it is middle meningeal artery. Rupture of cortical bridging veins, rupture, SDH. Middle meningeal artery ruptures, EDH. A clinical sense on this, like if you're attending an OT, surgeon has opened up the abdomen, he's doing a laparotomy. He cuts a vein in the abdomen, he doesn't panic, he just presses on that, it stops. But if the artery gets cut, he panics. He immediately cautery that artery or ligates that artery. Why? Because the blood column will come out as a spurt as per the blood pressure of the patient. Now I have a clinical sense on this. Listen to me. A patient of mine was walking comfortably. He or she had a history of fall. They have injured their head on the wall. On the side of the injury, they keep on having headache for the last 1 or 2 months. But on the opposite side, they develop hemiparesis. So that means that something is gradually and slowly increasing in size. A venous bleed. Simple answer. But same patient fell down, walked for a kilometer and then died. We did a post-mortem and we found an EDH. Why? Because the arterial rupture will bring out the blood as per the blood pressure. Whenever the patient strains more, it will increase, EDH. So we know that SDH often is having a slow and a very progressive kind of a story, SDH, while EDH very often is having an acute or a sudden kind of a thing. It's more of a sudden onset to region, EDH, more of a chronic progressive nature, SDH. Something from radiology I recall, how do they look like on a CT scan? SDH, the opacity or hypertensity is convex one side and concave on the other side is concavo-convex. While EDH, the opacity or hyperdensity is biconvex. So this time it is concavo-convex and this time it is biconvex, both side, one side, both side. Concavo-convex. Concavo-convex looks like a half moon, semi-lunar in shape, while this one looks like a lens, lenticular in shape. So concavo-convex opacity is semilunar and biconvex opacity is lenticular. Something, if you remember, word that you remember as lucid interval, I'm very sure you must be knowing this word from your forensic classes, is more in favor of EDH. I'll tell you one thing. I've seen this thing even written in Harrison, something vaguely like lucid interval can occur in SCH, SDH, EDH. All three of them he mentions lucid. The word lucid interval is a time in which the patient is perfectly normal looking, but something going wrong in his brain. I'll tell you one reference for this. Very often you see patients in your clinical practice found roadside unconscious. They come to the hospital conscious. You have a good laceration on the forehead. You tie the stitches on them and send the patient home because he is conscious. You don't worry to get a CT scan done. Patient walks to the casualty gate, collapse, dies, brought back. What is your differential diagnosis? EDH. Patient looks normal, but something goes wrong. EDH. Because the blood collection in EDH is slightly less initially, but as the patient strains, it increases, causes a midline shift and kills the patient. EDH. More emergency, EDH. Write down a question. A 62-year-old diabetic female presents with progressive right-sided weakness of 1 month duration. Presence is progressive 1 month duration weakness. Patient is also having a speech difficulty, some problem with the speech, and the fundus examination that we did shows optic disc coming up, which is known as papilledema. 2 months ago she had a history of fall and struck her head against the wall. Okay, fine. Diagnosis. Option A, Alzheimer's disease. Option B, left parietal glioma. Option C, left MCA territory stroke. Option D, left chronic SDH. Now the ball is in your court. A 62-year-old diabetic patient had a history of fall 2 months back. She had an injured head on the opposite side of the body. Very good. Very quick. D. See, names, whenever, I'll tell you one thing, in names, listen to me. In names, if you get a clinical question like this, there is a 3-tier arrangement of solving an MCQ there. First thing you should know, what is the answer? Secondly, why it is an answer? And the third most important step to be taken, why other people are not the answer. Okay, so what happens is, I should know what is the answer. We already know that she had a history of fall 2 months back and over a month duration, progressive chronic insidious kind of a story, right-sided hemiparesis, most likely SDH. We know this why? Because venous bleed accumulates slowly and gradually. Why not the other people? Alzheimer, out of question. Some student had asked me that day, sir, why not a parietal glioma? At an age of 62, very often gliomas, glioblastoma multiforme, very common at this age. And your patient is already having, sir, papilledema. Why not a brain tumor? Good question. But if my dear friend, if the patient is having a parietal glioma, patient should have some parietal lobe lesion. Patient should have AST diagnosis, loss of localization, scotoma, or at least that patient should have that Gerstmann syndrome which I taught you. Nothing like this is seen in the patient. I don't imagine it is a parietal lobe glioma so early. Some student had asked me, why not an infarct, sir? I say it is an infarct over a one duration, progressing over 1 month. No. See, whatever story I've told you like this, whatever story I've told you like this, the power goes from 1 by 5 to 4 by 5 embolic, power goes from 4 by 5 to 1 by 5 thrombotic. My dear friend, it all happens within 7 days. It doesn't take a month duration to happen. Too long a duration, 1 month. Shorter, 1 week. Okay. So ischemic, embolic, thrombotic, whatever you want to call, goes up and down within a week duration, not a month. Best answer, you already know, chronic STH. So like solve your queries. Least common site of berry aneurysm, I already answered, vertebro-basilar junction. The posterior most vertebro-basilar junction is the least common site. Chennai Center, sir, in SAH, SIADH will also increase. I don't get your question. Can you repeat this one? See, SIADH is a cousin brother of cerebral salt wasting. I will teach you next in the endocrine next to next class that it is euvolemic hyponatremia. This is hypovolemic hyponatremia. Okay. See, most of the time in patients with subarachnoid hemorrhage, which the book tells me is cerebral salt wasting disease, not SIADH. SIADH means more ADH, raised ICD. Yeah, anyone can have, but for SAH chapter I have read it clearly. It doesn't mention SIADH. He often mentions it as cerebral salt wasting disease. Okay. Vishakhapatnam Center, speech difficulty. You want to ask for this question, I believe? Yeah, speech difficulty is something focal deficit that can occur to anyone. Okay, patient might have some dysphasia kind of a story. See, Jammu Center CT with contrast, you learn more in radiology, is for seizure patient. A patient who presents to me seizure, I give a contrast. Refractory, impairment for refractory increase ICT. See, raised ICT, the best treatment ever is hyperventilation. You make the PaCO2, arterial carbon dioxide level, less than 30. You make the patient hyperventilate, that is the best. But the initial and the first that we often give is mannitol. Furosemide, I believe, is something which is not mentioned in Harrison in the protocol. There was one question, which of the following is not used in control of raised ICT? There was furosemide, there was steroids, there was hyperventilation, and there was mannitol. There were 4 options. In DNB, of course, DNB style question, typical one. Furosemide in Harrison doesn't mention furosemide. They don't give for raised ICT. You often give an osmotic diuretic to decrease the edema, that is mannitol. Okay. So mannitol is preferred over furosemide. But clinical practice we give furosemide. We do it wrong. It's not given actually. Not given in the book at least. Features of raised ICT, projectile vomiting. Okay, fine. As vomiting which is not preceded by nausea is projectile vomiting. Okay. Heading is delayed. I mentioned the heading as delayed. See, one thing which happens at the onset of SAH is thunderclap headache, LOC, neck rigidity, and no focal deficit. But as a focal deficit, vasospasm, focal deficit hemiparesis, बाद में, after some time delayed. Re-rupture, after some time delayed. Hydrocephalus, after some time delayed. Hyponatremia, not on day 1, after some time delayed. Okay. Now, one more important question. शिमला सेंटर तो It's come for studying today, I believe. Lunch break. Option A, yes. Option B, no. Option C, I don't know. Oh, so many A's. Aldwani Center is very hungry. Oh, I don't know. Dipluga Center. Okay. Okay, fine. No problem. Tama. Arey, bas. Time. Oh, 1 hour. Babre bab. Mysore Center. Don't go to Bangalore and have lunch there. Sit in Mysore only. ಏನು ಮಾಡ್ತೀವಿ ನೀವು ಊಟ ಮಾಡಿದ್ದೀವಿ 1 hour. What do you do? Time 15 minutes, 20 minutes, 25 minutes, or 30 minutes. Okay, fine. Bas. 45 minutes Aurangabad, babre baap. We'll make it half an hour. Okay, maximum half an hour. I'll start after half an hour. Okay. First 2 hours, Bilaspur Center, which first 2 hour? You want to start with the seizure or stroke? Tell me this. Seizure disorder? Bilaspur Center, seizure disorder, no? Starting morning, yeah. Okay, fine. Okay, we'll display it in this introduction part. So let's restart. Yep. Now we'll see another disorder, which is a degenerative disorder of the brain, Alzheimer disease. Alzheimer disease, a degenerative disorder of the brain. Alzheimer disease is a disorder degenerative in the brain. It only occurs due to atrophy and due to a process A again, amyloidosis. So we understand that there is a protein in my body which is a precursor protein, APP, Alzheimer or amyloid precursor protein, that suddenly changes its own structure and becomes a beta plated structure, A beta peptide. So normal protein changes its own structure, becomes a protein that is different from the body. Most important thing, if you read amyloidosis as a topic in pathology, you learn that amyloid proteins are toxic to the cell wherever they form. Like you see amyloid kidney, you see renal failure. You see amyloid heart, you see cardiomyopathy. You see amyloid brain, you see Alzheimer disease. So we should realize that amyloid proteins are found in the body which are always toxic to the cell where they are occurring. Like in the brain, if they occur, A beta peptide. It is toxic to the cell where it is seen. It is neurotoxic. It is resistant to degeneration. It is resistant to degeneration, and 1 and 1 together will become 11. It often aggregates rapidly. So we realize that any amyloid protein has got this quality, same with that of the A beta peptide, Alzheimer protein, amyloid protein. Now we understand that this problem of APP to A beta peptide generation doesn't happen in every one of us. There has to be a genetic focus or a genetic locus that forms this kind of a story. There are certain chromosomes which are responsible for this kind of event. Chromosome number 21, chromosome number 14, chromosome number 1 and chromosome number 19. So there are 4 chromosomes, a defect on them can cause this kind of a disorder. Chromosome number 21, it encodes for the first thing that happens, amyloid precursor protein, APP. A formation of this amyloid precursor protein will take the story further to end at A beta peptide. If you recall something from your knowledge that trisomy 21, Down syndrome, a patient with Down syndrome is down with Alzheimer by an age of 21. It really happens because of this kind of a disease. Pre-selin 1, that is formed from your chromosome 14, and intermediate substance pre-selenin 2. So they cause a protein intermediate being formed, pre-selenin 1, pre-selenin 2, which actually directly increase the generation of A beta peptide. So the toxic substance, that is A beta peptide, that is formed in the brain, the formation of it is often increased by by 14 and 1 chromosome, pre-selenin 1 and 2. Chromosome number 19 forms an intermediate substance, apolipoprotein E or epsilon 4. Epsilon 4 actually increases the risk of Alzheimer's disease. Sorry. So there are 4 chromosome numbers which cause the disease, 21, 14, 1 and 19, and this is how they cause the problem. Now we understand that there are certain factors which actually increase the risk of Alzheimer's disease and factors which decrease the risk of Alzheimer's disease. Factors which actually increase the risk of Alzheimer's disease, one of them elderly population, more often seen in the elderly, more often seen in the female population, more often seen in the people who have got low education. So people who are low educated had the disease very often, that was a risk factor. Thank God, at least this disorder will not have, you have got higher education. Aluminium, a toxin, actually not a toxin, metallic product, aluminium, exposure to that can cause Alzheimer. If you remember from nephrology, dialysis, dementia kind of a story, a patient who is on dialysis is often exposed to aluminium. Chronic exposure to aluminium can cause dementia, dialysis dementia kind of a story. Factors which decrease the risk of Alzheimer, one of them is this, post-menopausal estrogen therapy. A female who got post-menopausal estrogen therapy had a lesser risk of Alzheimer. People who had carried with them this ApoE2, like ApoE4 increases the risk, ApoE2 decreases the risk. And people who are smoking. See, smoking is always injurious to health, we know this fact. Smoking can provide you protection against some inflammatory bowel disorder, against Alzheimer, against Parkinson disease. Okay, smoking can have a protection in some of the disorders. Now, if you understand that if you see a patient with Alzheimer, they usually have got atrophy of the brain, atrophy of the temporal lobe, and atrophy of the parietal lobe of the brain. So that was an AIMS question few years back, that in Alzheimer's disease, which part of the brain actually atrophy? It is temporoparietal lobe atrophy, and then it shifts inside the brain and it affects the hippocampus. So there is a temporoparietal atrophy with hippocampal atrophy seen in the patient. If I remember something that we have just read, something working immediate memory. Working and immediate memory is stored in the temporal lobe, that somewhere becomes a hard disk, and then is converted into a long-term memory in hippocampus. So my patient basically has got a problem in remembering what he or she had for food. They keep on having breakfast, they again keep on having breakfast, and then forget that they had the breakfast done. They will move from one other room to the other room and they will forget what they can come in for. And day-to-day activities like who became the Prime Minister, they don't remember after 1 month because hippocampus is involved. They cannot convert the story into a long term. So that's a very typical kind of a deficit that you see in a patient with Alzheimer's disease. Immediate short-term recall first, and then the day-to-day activities are not registered into a pen drive because hippocampus is involved in the patient. Now, to discuss this disorder, Alzheimer, we can see the story in a form of a big A. Story in a form of a big A. To start the A, we got a atrophy. TPH, temporoparietal hippocampus. Temporoparietal hippocampus atrophy. So there is an atrophy in the brain that you see in the temporoparietal and hippocampal area. The amnesia which the patient feels is anterograde amnesia. So the A with A, anterograde amnesia seen in patients with Alzheimer's disease. Unfortunately, they are not aware of the problem, anosognosia. The word is unaware. They are unaware of the problem because of this anosognosia. Anosognosia means unaware of the disorder, lack of insight, anosognosia. Then these patients often have got aphasia, which is put in the word as an anomic aphasia. They are often dependent on the people around to work, which is unable to move around, apraxia. And lastly, agnosia. See, I told you as for a reference, a mobile phone you saw, you answered it as a mobile phone. If a patient answers this mobile phone as a transistor, he knows it's for listening, but he cannot name it properly. Anomic aphasia. The same patient saw a mobile phone and answered it as a biscuit. That is even worse. He doesn't know the function, cannot identify agnosia. So agnosia is a big brother of anomic aphasia. Now, the story often ends with an A in their life. The story often ends with an A in their life, that is aspiration pneumonia. So cause of death which has been listed in the journal articles of Alzheimer's disease patient is aspiration pneumonia very often. The neurotransmitter that often goes down less in the brain is central acetylcholine. So they have found that acetylcholine level centrally goes down in a patient with Alzheimer's disease. And an A which is often not seen in the patient that can be possibly is acalculia. So acalculia is not seen in the life of Alzheimer's patient. There is a diagnostic criteria that you often discuss in psychiatry, DSM criteria. In that DSM criteria, there are diagnostic criteria for Alzheimer. In the diagnostic criteria, they don't find acalculia as a feature. So there was a question in AIMS that we had faced around 2 years back, that which of the following is not seen in Alzheimer's disease? Aphasia, apraxia, agnosia or acalculia. Answer is acalculia, simple one. But someone had put up a question in the guide recently as, which of the following is not seen in early onset Alzheimer? Agnosia. Early onset means which comes in early in life. At an age of 21, if someone has got Alzheimer, maybe a Down syndrome patient, in that patient, agnosia is not seen. There is a diagnostic criteria, ICD criteria. Like there is a DSM, there is also an ICD criteria to define various disorders. As per that ICD criteria, in early onset Alzheimer, agnosia is not seen. Okay. So there are two questions with me. One which is not seen in Alzheimer, acalculia. One which is not seen in early onset Alzheimer is agnosia. A. Now the B. Something related to the behavior of the patient, that is a delusion. Delusion, if you remember from psychiatric classes, is a false belief. Patient feels that someone is going to kill him. Such a kind of a false belief if a patient has is known as a paranoid delusion. Paranoid delusion of such a variety that he feels that the doctor, especially a nurse, doctor or caregiver or even the guardian, has been replaced and has become someone else, has become a doctor and coming and treating him, is going to kill him one day. Paranoid delusion. This kind of a story which I told you, that the doctor has been replaced and is going to kill him, paranoid, is known as Capgras syndrome. So there was a syndrome that was seen in Alzheimer's disease patient known as Capgras syndrome, in which the patient feels as if someone has been replaced with a doctor. Someone has been replaced by the doctor and is going to kill him. Paranoid, false belief, 10%. They found that not everyone, around 10% of patients with Alzheimer's disease had this kind of a trouble. Paranoid, delusion, false belief, doctor has been replaced, Capgras syndrome. In the brain, very often, one thing which is not seen, confabulation. In the clinical symptom, confabulation means a false story. If the patient is aware that he or she is suffering with a memory loss, I am very sure they are very smart enough to hide it from the community around them. Otherwise, people will not meet them, people will not give them money, they will take the money, forget it. So that's become a problem. So confabulation is not seen in the patient of Alzheimer. They are not aware of the problem, they do not put up a false story. I'll give you one reference for this. Someone moves of it is out at 9 a.m. in the morning. He roams around till 1 p.m. He doesn't know what has happened for the last 4 hours. He'll come back home, tell everyone that he was here, he was there, he was here. Everyone will believe him with a false story. Fill in the blank. False story, confabulation. But this power is not with an Alzheimer patient. Most of these patients are not aware of the problem, so they don't confabulate. A patient who confabulates very often is a patient who drinks. A patient with alcohol dementia. So patient who is drinking, having dementia, alcohol dementia, often confabulates. Not a patient with Alzheimer very often. In the brain, in Alzheimer's disease, we don't see infarct. Very important statement to be made. If you see infarct in the brain, if you see dementia, it is a vascular dementia. The vessel of the brain is at fault. So vascular dementia is a term that you use for defining a patient having infarct in the brain and having dementia very often on. Vascular dementia. Okay. So Alzheimer's disease patients don't confabulate, don't have infarct in the brain. They do have a delusion in 10%. They've got all the A's in their life except for acalculia, but in early onset Alzheimer except for agnosia. Okay. We saw two questions on this point, two different type of questions. Write it down. November 2011 in AIMS. Which of the following sorry, just a second. Which of the following is not seen in Alzheimer's disease? Option A, aphasia. Option B, acalculia. Option C, apraxia. Option D, agnosia. Which of the following is not seen in Alzheimer's disease? Fine. Rhythm correct. Acalculia is the correct answer. For why? DSM criteria. But the question that I saw in one of the guide recently was different. The question read was different now. Which of the following is not seen in early onset Alzheimer's disease? Early onset Alzheimer's disease, which of the following is not seen? Tell me now. A, B, C, D. Then it becomes D. Because in early onset Alzheimer you find acalculia but you don't find agnosia. The definition this time is on the ICD criteria. So you got two questions in your guide, two different answers. You know it by now. Note down another interesting question. A 80-year-old person, a 80-year-old male, I shall make it female, 80-year-old female has started forgetting names of familiar person and places. She often forgets what she had for meals. There is no confabulation. Central nervous system examination is normal. CT scan of the brain that we did for the patient had got a symmetrical enlargement of ventricles of the brain with wider sulci. The diagnosis that you can put in this patient: option A, confusional state, option B, Alzheimer's disease, option D, alcohol dementia, option D, chronic cerebrovascular insufficiency. Okay, what should we answer? I believe a clear-cut answer at this point is B, Alzheimer. You know it why? Yes, because this patient doesn't have a confabulation. He on a CT doesn't have an infarct. In fact, he had an age-related cerebral atrophy, a finding that you often see on a CT and MRI report written no. The atrophy of the cortex will give more space for the ventricle to enlarge in the skull bone. So the ventricle enlargement is not hydrocephalus. It is a enlargement that you see as a compensation because the cortex has atrophied. So this patient doesn't have an alcohol, doesn't have a chronic cerebrovascular insufficiency. Alzheimer's disease is the best answer. What is this confusional state, if you have any idea? You and me have it. When we go for exam, we have got retrograde amnesia. What we have read, we forget. For 3 hours, we keep on having that anterograde amnesia. We don't know what we are attempting at. Stress-induced confusional state. Okay. So it involves retrograde and anterograde both. Okay. Doesn't show a CT scan finding at all. It's normal. Now we'll dig into the brain and we'll see what is seen in the brain on microscopic finding. When the beta plated structure went into the brain cell, it doesn't have much of a space. It revolved like this. Instead of the typical beta plated structure, it became tangled loops and coils, which are known as neurofibrillary tangles, NFT. Number 1, neurofibrillary tangles. NFT. Neurofibrillary tangles are seen within the brain cell. They are seen to be intracellular. They are often correlating with the severity of the patient or severity of the disease. More severe the problem, no number of neurofibrillary tangles that you possibly see. Within the neurofibrillary tangles, we have got tau proteins. Tau proteins are nothing but hyperphosphorylated microtubular protein. So you got certain microtubular proteins in the brain which get more phosphorus on it, that is known as a tau protein. Tau protein is suggestive of neurodegeneration. Wherever you get neurodegeneration, you find a tau protein within it. This tau protein is not exclusive for Alzheimer's disease, mind you. In patients with Alzheimer's disease, you find tau proteins, yes, and a different disorder similar to Alzheimer's that you can find in is this frontotemporal dementia, well abbreviated as FTD. Frontotemporal dementia, dementia or memory loss due to lesion in the temporal lobe, storeouts for immediate and short-term memory, but frontal lobe also getting involved. In Alzheimer's, I never mentioned the frontal lobe lesion. I mentioned it as temporoparietal. This time the frontal lobe. If the frontal lobe is gone, one thing which I know, the patient will often have a behavioral abnormality. So in patients with lesion in the frontal lobe, they have got a behavioral abnormality very often. The age of onset of these patients have been found to be usually less than 65 years. and the insight, that is the understanding part, that they are unwell is not preserved. Insight is not preserved, the age of onset is less than 65, and they've got a behavioral abnormality within them, that is known as frontotemporal dementia. Apart from the FTD, this tau protein are also seen in patients with PSP. Already topic which we have discussed in the morning session: extended posture, defective downward gaze, history of fall with dementia. The reason of dementia now we know is tau proteins. So tau protein are suggestive of neurodegeneration. See, the story is like this: there is degeneration, there is dementia, and ultimately the patient dies. 3D formula. All these three have got tau protein within them. So they are disorders which exhibit tau protein for neurodegeneration, known as taupathies. So taupathies are disorders in which the tau proteins are seen. One of them Alzheimer, a perfect example. Second one is frontotemporal dementia. Third one is progressive supranuclear palsy or PSP. Now, second marker of degeneration that we possibly see in the brain is a senile neuritic plaque, well abbreviated as SNP, senile neuritic plaque. Senile neuritic plaque are seen outside the brain cell. It is seen extracellular. The word senile is given to it because it is often correlating with the age of the patient. More advanced the age, more the number of senile plaques that their patient has. Senile neuritic plaques can also be seen in a normal aged brain. That was a finding, 68-year-old Babaji died due to some reason. We did a brain biopsy on him. We found a senile plaque. Doesn't mean that the patient is suffering with Alzheimer. See, it can be a normal variant also in an advanced ages. So it often correlates with the age. Like NFT correlates with severity, senile neuritic plaque correlates with the age of the patient. Why do the senile plaque at all appear? Senile plaque occur in the brain due to this problem: cerebral amyloid angiopathy, well abbreviated as CAA. Now whatever the beta plated structure could not enter into the cell, it remained outside the cell, extracellular, on the vessel, angiopathy. So beta plated amyloid on the brain vessel, cerebral angiopathy. This angiopathy can occur on a larger vessel of the brain. ACA, MCA, PCA, what we had made in the circular village, a larger vessel, or can be occurring on the vessels that arise from the larger vessel, penetrating arteries, smaller vessels. Large vessels of the brain are involved, the cortex of the brain is involved, cortical disorder. Small vessels are the vessels that arise from the large vessels sending the blood deep into the brain. So areas below the cortex are involved, subcortical. So we got two kinds of dementia that we remember: cortical and subcortical dementia. Okay. Example: Alzheimer's disease is a perfect example of cortical dementia. PSP, basal ganglia, subcortical zone, subcortical dementia. So moral of the story is that Alzheimer's disease is related to cerebral amyloid angiopathy via a large vessel, not a small vessel. And one thing very important, Alzheimer is a cortical disorder. We'll come to that when we discuss a question on this. Third type of pattern that you see in the brain is a granulovascular type of degeneration. So we see the degeneration in the brain, which is of a pattern that is known as granulovascular degeneration. Okay. Now I'll compile everything and put it in short duration notes like this. The Alzheimer's disease actually starts at a point amyloid precursor protein, which changes its own structure, becomes a A beta peptide. The A beta peptide very well enters the brain cell. It becomes a neurofibril tangle. Neurofibril tangles are often having a direct relation to the severity of the disease. Within the neurofibril tangles, we have got a tau protein, which is suggestive of neurodegeneration. Outside the cell, this beta plated structure, when on the large vessel, On the large vessel, it causes cerebellar-myelite angiopathy. Because of that, there is formation of senile neuritic plaque (SNP). Remember one way: number 1 NFT and number 2 SNP always. Number 1 NFT, number 2 SNP. Initially in the disorder, NFT are formed, later on SNP are occurring. First intracellular and then extracellular. And the neurotransmitter that possibly goes down, acetylcholine. We know this. In Parkinsonism, different kind of story is seen, that is known as Lewy body dementia, well abbreviated as LBD. Actually, you can put the topic as Lewy body rather than putting as Lewy body dementia. What is Lewy body? First, the definition of Lewy body. Lewy body is defined as intraneuronal, intracytoplasmic, eosinophilic, intraneuronal, intracytoplasmic, eosinophilic inclusion body. Intraneuronal, intracytoplasmic, eosinophilic inclusion body are very well labeled as Lewy body. Lewy body are seen in patients with Parkinsonism. Yes, it is seen in patients with Parkinsonism, and it is very often seen in patients with Lewy body dementia. LBD, a topic in which we remember a patient of Parkinsonism who has come to me with visual hallucinations. So visual hallucinations are never a feature of Parkinsonism patient. If such a thing occur in the patient, it is known as Lewy body dementia. So it comes in a plus kind of a thing, no? Atypical kind of a thing. So the plus or atypical story that we discussed in the morning session, TSP, MSA, and the third brother is LBD, Lewy body dementia. Remember one thing very clearly, Lewy body is not seen in patients with Alzheimer's disease. Lewy body are seen in Parkinsonism and Lewy body dementia, are not routinely seen in patients with Alzheimer's disease. Chalo, note down some questions on this. Write this one first. All of the following about Alzheimer's disease is true except option A, number of क्या हो रहा है यार, number of senile plaque correlate with age. Option B, underlying tau protein suggests neurodegeneration. Option C, number of neurofibrillary angle is associated with severity of dementia. Option D, extracellular inclusions can be found in absence of intracellular inclusions. Which of the following is not true about Alzheimer's disease? Number of senile plaque correlated age, underlying tau proteins such as neurodegeneration. Fine, good, rhythm correct. I believe you understand the topic well. Number of senile plaque correlated, that's correct. Underlying tau proteins such as neurodegeneration, that's also correct. NFT correlate with severity, that's also correct. But extracellular inclusion are found without an intracellular inclusion, that's not correct. For one reason, you find an intracellular first and then you see an extracellular after it. It is never exclusively. Exclusive extracellular, that is only senile plaques come into the picture. That means the patient is possibly having a normal aged brain. Okay. Now one more question at this point, write it down. In Alzheimer's disease, neurofibril tangles are not seen in visual association area, cingulate gyrus, anterorhinal cortex, lateral geniculate body. Any ideas for this one? In Alzheimer's disease, neurofibril tangles are not seen in visual association area, cingulate gyrus, anterorhinal cortex, and lateral geniculate body. Don't think it's a tough question, it's an easy one. See, Alzheimer's disease is a cortical disorder. If I look at the areas which are cortical, visual association area, cingulate gyrus, anterorhinal cortex, all three of them in the cortex. Okay. Lateral geniculate body out of them is someone subcortical, below the cortex in the thalamus. So lateral geniculate body won't see a neurofibril tangle coming into it. Okay. So answer is D, the best answer. Anglo-Saxon single most risk factor for Alzheimer, female, age or family history. Family history won't come into the picture so often. Female, age. Age would be the best out of the three. Okay. Now we'll proceed. Now we'll see another disorder related to dementia, that is Huntington chorea. A very simple and easy to understand disorder, Huntington chorea. Huntington chorea occurs due to problem on a gene discovered by a physician, Mr. Huntington, and the gene named after him is Huntington gene. Huntington gene is located on chromosome number 4 and it is a short arm of the chromosome number 4 that causes this problem known as Huntington chorea or Huntington disease. Basically it causes this trinucleotide repeat sequence defect. So we see a trinucleotide repeat sequence defect in patients with Huntington chorea, and it occurs basically due to Huntington gene which is located on the short arm of chromosome number 4. Now the sequence that is at fault in these patients is the CAG sequence. We found that the codons and anticodons, the trinucleotide repeat sequence, they are 3 in number If they're 3 number, they will form a transcription, translation, and then a protein of a normal structure and a normal value. But in this case, the CAG sequence, that was a trinucleotide repeat sequence, was abnormally long. Instead of the number 3, it became 30,3 lakh. It elongated and produced a protein that was a defective protein. Now, if it is a gene, it has to come down in the family in a form of an inheritance. The inheritance pattern that occurs in this patient is autosomal dominant inheritance. Try to understand the word autosomal dominant. Firstly, 2 successive generations are affected. In the patient, the father, the grandfather, the grandmother, they are affected, or the maternal grandfather, maternal grandmother, or the mother is affected. On the paternal or the maternal side, 2 successive generations have to get affected to call a disease as autosomal dominant. One more clause attached to this is if one parent is affected, chance of the disease that you see in the children is 50%. That is 1:2. What do we understand by this drama? We've got husband, wife, and 4 children. If one parent is affected, the chance in the offspring is 1:2, 50%. Out of 4, 2 are affected, 2 are not affected. If both parents are affected, possibly, if both parents are affected, the chance of the disease in the children is 75% or 3:4. If both parents are affected, chance of the disease in the children is 3:4, 75%. We can again make a family tree for understand this problem. V2 or 4. If both parents are affected, chance of the disease is 3:4. Out of 4, 3 are affected. Okay. So 30%, 3 to 4, 75% chance if both parents are affected. 50% 1:2 chance if one parent is affected. That is for any XYZ autosomal dominant disorder. We should know this fact. Now in the chapter of Huntington's chorea, they mention 2 more troubles. One of them is anticipation. Anticipation basically means that to anticipate when the disease is going to happen. If you happen to have the disease from the father, it slightly comes in early. It is slightly of an early onset. And if you inherit the disease from the mother, it usually comes in late onset. The early onset means somewhere in the 2nd decade of life. Late onset basically means somewhere in the 5th decade of life. So the anticipation guarantees me that the disease has to happen beyond 11, and if it all has to happen, it will occur till 50 years of life. So we understand there is always a bracket for onset till the upper limit, that is 50 years in the patient. Why such an event happen? Because of this phenomena which is known as lengthening. Lengthening means we need to lengthen it out. They claim in the book that larger the defect, more severe is the problem, and possibly early may be the onset. So normally it is a sequence of 3. A sequence of 3 becomes 30,000. A larger defect. A larger defect will produce more severe the problem and more early the onset in the patient. So they claim in the book like this: if you inherit the disease from the father, in the subsequent generation lengthening happens. It happens at an early stage because of lengthening, anticipation. So because of lengthening, you get anticipation kind of a story. Clinical features. A love triangle again. Autosomal dominant inheritance. A movement disorder, chorea. And a memory loss problem, dementia. Whenever you find dementia, it often occurs last. In advanced stages of the disorder, you find dementia in the patient. One thing about chorea, if you remember, if you see chorea, you see atrophy in which part of the brain? We already discussed this thing. Atrophy is seen in the caudate nucleus. So C for chorea, C for caudate nucleus. One more story to tell. Whenever you have a deficiency of this neurotransmitter, acetylcholine, you'll have amnesia. Acetylcholine is always opposite to dopamine. In Parkinsonism, dopa was less, acetylcholine was more. This time acetylcholine is less and dopa is more. Acetylcholine has got a good friend to live with, GABA. So this trouble is known to be intrastriatal. There is an intrastriatal loss of cholinergic and GABAergic activity that is seen in the brain of the Huntington's chorea patient with an atrophy in the caudate nucleus with an autosomal dominant inheritance of chorea and dementia. Now the story is like this. I saw a patient with a dance-like movement chorea in my OPD. I thought this is Syndrome's chorea, rheumatic chorea. I misdiagnosed him. I started him on benzathine penicillin and the patient deteriorated. Why? Because over a period of time, I did not ask one thing, a clinical history, a family history. If there is a family history of chorea in an autosomal dominant mode, everyone will die because of this death factor, dementia. Okay, so every patient of chorea that you see in clinical practice is not rheumatic. It can be because of this other troubles like Huntington chorea. Treatment, a very simple one. There's a lot of confusion on this also. Treatment. We offer dopaminergic antagonist to the patient. Haloperidol is one drug that is used for this. There's a lot of controversy. Some books say dopamine depleters are given, but dopamine depleters are good drug like tetrabenzene, but they have got a lot of side effects. We preferring using dopaminergic antagonists like haloperidol. Okay. Chalo, write one question at this point. Our family consists of husband, wife and children. Wife's father is having Huntington chorea. Which statement is true? Chance of getting the disease is 1:4. Can occur up till age of 50. If wife does not get the disease till age of 50, children are not affected. Option D. Huntington chorea is due to point mutation in gene. A family consists of husband, wife and children. Wife's father is suffering with Huntington's chorea. Which of the following statement is correct? I see. Rhythm correct. To understand this drama, let's make a family tree that will be better. We've got a husband, got a wife, got 4 children. That's the family tree that we have. Husband, wife and possibly 4 children. Wife's father is suffering with Huntington's chorea, a generation above my mother and generation higher above me. Which of the following statement is correct? Option A was chance of getting the disease is 1:4. If one parent is affected, chance in the subsequent generation is 1:2, 50%. If mother got affected in the subsequent generation, is again 50%, 1:2. It is never 1:4 in any of the generation. Don't play a law probability here. Okay, in this generation to this generation is 1 is to 2, in the next generation 1 is to 2, 1 is to 2, 1 is to 4. That means out of 4 only one child is affected, not an autosomal dominant disorder. So A is out of question. Option B can occur up till age of 50 if at all my mother was affected. If at all my mother was affected. Very important statement. Anticipation. Late onset at an age of 50. But in the question, the mother isn't affected, so option B is incorrect to some extent. But I'll always keep it as a plus minus kind of a story. Option C. If wife does not get the disease till age of 50, children are not affected. What does option C mean? Option C is very clear cut. Option C means this. If wife does not get the disease till age of 50, the upper limit for the disorder to occur, her brother, her sister, is that they are affected. So we have a disease in her generation in a ratio of 1 is to 2 or 50%. If wife does not get the disease till age of 50, children are not affected. That will become more comfortable and an easy statement to make. Option C is much better than B. Okay, because option B is true only when my mother was affected, but that's in the question, not when affected at all. So we'll keep C better than B as an option. As far as D is concerned, it is due to point mutation in the gene. No, it is due to trinucleotide repeat sequence defect. Okay. Now we'll discuss another easy one topic, one simple one, that is known as normal pressure hydrocephalus. NPH. Already mentioned this word earlier. Hydrocephalus means enlarged ventricles of the brain. Enlargement of the ventricles I see whenever I have a raised ICT, but this time the ICT wasn't very high. It was in a high normal range. The way that we told was normal pressure hydrocephalus. Why? Because we know that the CSF pressure normally is in a range of 50 to 180 millimeter of water. In a patient who is having NPH as a disorder, it becomes 150 to 200. It becomes high normal. So it's not very high, it's high normal pressure that you see in the brain, normal pressure hydrocephalus. Whenever we see a raised ICT, it often occurs due to this basic problem, decreased CSF absorption. Okay. Why a decreased CSF absorption? Because the blood comes and sits there, subarachnoid hemorrhage. Sometimes there is inflammation in the meninges that you see, meningitis. So these are the two reasons to cause a decreased CSF absorption very often, and raising the ICT but not to in a very high range with hydrocephalus NPH. Clinical features. A love triangle again. It's very good, sir. The mnemonic is good. Gait ataxia. Urinary incontinence with a memory loss that is known as dementia. Remember this way, whenever you see dementia with 2 or 3 more symptoms, it often occurs later in the disease. It is seen often last in the disorder, not very early in the disorder. Okay, because I saw one of the guide mentioning that urinary incontinence occurs in later half. No, it is the dementia which occurs last. Treatment, no problem. I have a problem in absorption of the CSF, but I have a place where the CSF is absorbed 100% 24 hours, peritoneal cavity. So I put a tract between the ventricle of the brain and the peritoneum, VP shunt, ventricular-peritoneal shunting. If you do a ventricular peritoneal shunting, they write in the book that the most responsive symptom that you see is ataxia. So ataxia is the first and the most responsive kind of a thing that gets corrected in a patient who has undergone a VP shunt, in a patient with normal pressure hydrocephalus. Similar kind of a story, ataxia and all, can occur in a patient who is drinking a lot. A very famous one, Wernicke's encephalopathy. Wernicke's encephalopathy often arises due to deficiency of thiamine. Thiamine is vitamin B1. Okay. This kind of thiamine deficiency often occurs in patients who are vomiting a lot, hyperemesis, and in patients who are drinking a lot, alcohol intoxication, maybe a chronic intoxication, maybe a once in a while binge drinking, either of the two. Clinical features: love triangle again, and a favorite place to drink and dine, Goa. Global confusion, ophthalmoplegia, and ataxia. So, got a global confusion, ophthalmoplegia, and ataxia as a triad that defines a patient with Wernicke's encephalopathy. Treatment, very simple one. You replace the thiamine, patient will get better. Thiamine replacement done for the patient at a dose of 100 milligram per day. Okay. A big brother of Wernicke's encephalopathy that I recall is Korsakoff psychosis. These are patients who have got dementia, yes, and they hide it out from the people by telling a false story known as confabulation. So dementia with confabulation falls into one category that is known as Korsakoff psychosis. Okay. So we'll write one question at this point to understand this topic. A 60-year-old alcoholic male, a 60-year-old alcoholic male presents with urinary incontinence, abnormal gait with memory loss. Diagnosis: Huntington disease, NPH, Wernicke's encephalopathy, Alzheimer disease. Only Aurangabad center was carried away by the word alcoholic, I believe. Every male who drinks doesn't go to Goa, yaar. It's not a Goa triad. It's good triad. Urinary incontinence, gait ataxia with memory loss, dementia. Okay, good triad, NPH. I purposely bring this question because half knowledge is always dangerous. You see the word alcoholic and you'll mark Wernicke's. No, it is NPH, not Wernicke's encephalopathy. Now we'll take the story further. Any doubts in this chapter of Alzheimer, dementia and all? Any doubts? Or all is well? Repeat. Alzheimer treatment you'll learn more in pharma, yaar. Leave it there only. Treatment of NPH I have already told, it's VP shunt, ventriculoperitoneal shunting, okay, in which you put a bypass tract between the ventricles and the peritoneal cavity. Yeah, in early onset Alzheimer we have got acalculia, different thing. So now we'll discuss another topic. that is headache. Headache are basically divided into two basic headings. One is one which is having obvious cause, that is a secondary headache. One which is not having any obvious cause, that is a primary headache. See, secondary is also a solution sometime, has got a treatment. Primary is always a problem but doesn't have a good treatment. So we divide the headache into two types: secondary solution headache and a primary problem headache. First, the secondary headache types. One of them very famous, temporal arteritis, and the second one which we will discuss is pseudotumor cerebri. I'll be discussing these two topics in greater details. There are longer list of secondary headaches like sinusitis, brain tumor, meningitis, post-LP headache. These are all very obvious kind of a story, but these are two unusual types: pseudotumor cerebri and temporal arteritis. Primary headache, one of them tension headache, second one migraine, and the third one that we need to know is cluster headache. So these are three kinds of headache in the heading of primary, and two basic headaches that we discuss in detail, that are secondary headaches, temporal arteritis and pseudotumor cerebri. We'll start with the temporal arteritis first. Firstly, important point is that which age group is commonly affected. It's elderly age group, more often the female than the male population. Temporal arteritis. If you remember the word temporal artery is superficial. It is outside the skull, just beneath the scalp, and there is an inflammation in it. So I believe, as per the heart beating, the blood moves in that inflamed segment. Patient knows it is moving. He feels it is moving. It is a throbbing or a pulsating kind of an headache. So the headache that the patient typically feels is a throbbing headache. Other type of headache that the patient often gets is a stabbing kind of headache. That means it's running outside the skull, so patient will feel as if someone is stabbing him from outside. A stabbing kind of headache, a throbbing kind of headache. And these patients often have a tendency of scalp tenderness. That means when one touches the scalp or the temporal region, the pain often increases. Why? Because you're touching the inflamed part of the artery if you're touching the scalp. So that is known as scalp tenderness. That's why they write in the book, this kind of headache often increases on a lying down posture. Patients lie flat on the bed, pillow comes in contact with the temporal bone, the pain often increases. So this patient often experiences the increase of intensity of the headache in a lying down posture. Scalp tenderness indirectly. One of the very specific symptoms that we see in the patient is jaw claudication. Claudication gives me a word as a deja vu. I read this word in my surgery classes. I walk, I get pain in the limbs. I stop walking, I relief of pain. Claudication, a symptom that you see very often in the limbs in the peripheral vascular disease. You move, you get pain, you stop, you get a relief. So claudication was a symptom that occurs in any vascular pathology. I remember temporomandibular joint is supplied by temporal artery. There is an itis there, inflammation there in the artery. It is not able to supply the joint very well. So the patient moves the jaw while talking, while eating the food. Patient gets a pain, jaw claudication. Okay, so jaw claudication comes in as a very specific symptom for this kind of a disorder. Apart from this, one of the most dreaded symptoms that we see in the patient is blindness, often an irreversible kind of a story. This season we got a difficult question, that posterior ciliary artery is the artery that is involved to cause a blindness in the patient of temporal arteritis. Okay. Investigation. If you want to investigate such a patient, one thing you can rely on is ESR. But mind you, normal ESR does not rule out the disease process. You can often get a patient with a temporal arteritis full blown kind of a story, even with a normal ESR. Okay, so sometimes over the period of time I saw a patient with temporal arteritis with a normal ESR, because itis phase has already gone off in the patient and it has caused a complete thrombosis or some thickness of the artery, so the ESR was normal. So the normal ESR does not rule out the disease. So we rely very often on a temporal artery biopsy. We go ahead and do a temporal artery biopsy. If I do a temporal artery biopsy, what do I find? I find a giant cell. One of the very typical questions that we found was giant cell arteritis. Another name for temporal arteritis, giant cell arteritis. This season we got a difficult question that what is the length of the temporal artery to be taken minimum for temporal artery biopsy. Minimum length is 3 centimeter. Harrison mentions it as this: 3 to 5 centimeter is the actual length of the biopsy to be taken for temporal arteritis diagnosis from a temporal artery. So minimum length for a good biopsy or a good yield of a diagnosis is minimum length is 3 centimeter. Treatment: for any itis I give steroids. Yes. So remember this way, drug of choice is only steroids. It is not any immunosuppressant other than the steroids. It is not isothiopurine, it is not cyclophosphamide, it is not NSAID. It is simply basic steroids. Okay. I'll give you one question at this point. Write it down. A 50-year-old male 50-year-old male came to emergency room with complaints of unilateral headache, diplopia, and difficulty in chewing food. MRI done was normal. ESR is high. Treatment: what to do? Aspirin, Coxib, prednisolone, valproate. 50-year-old male has come to you with diplopia, difficulty in chewing food, with unilateral headache, ESR normal. Good. Bas. You understood the point? It's a clear-cut case that you see of temporal arteritis or a giant cell arteritis. Okay. So there's no doubt on this. It's a clear-cut case of temporal arteritis, difficulty in chewing food. That is diplopia. Good question. Why diplopia? I mentioned blindness. Why diplopia? I read this thing in the giant cell arteritis chapter. Sometimes those giant cells can infiltrate into the extraocular muscles. They can weaken it and the patient might have diplopia also. It can occur. Nothing rare to happen. Okay. Blindness I mentioned as the most dreaded symptom, but diplopia in between can also happen in the patient. For such a patient, only steroids. Now I'll take the story further. Pseudo tumor cerebri. Pseudotumor cerebri is often seen in the young obese female population. Is most commonly seen in the young obese female population, pseudotumor cerebri. Now I have a patient who has got a brain tumor. What the patient has is got an headache. With the headache, the patient has got one symptom which we know as projectile vomiting. A vomiting that is not preceded by nausea is known as a projectile vomiting. And a very important sign of the disease that you see on a fundus examination is papilledema. But the word is pseudotumor to signify me one thing. It is not a tumor actually. It looks like a tumor. It looks like the fern is having brain tumor. But it's like a tumor? pseudotumor, a false tumor. If a tumor was in the frontal lobe, behavioral abnormality would have come in. If it was in the parietal lobe, learning disability would have come in. If it had been in the temporal lobe, Gajini would have come in, memory loss. Occipital lobe, vision defect would have come in. But this time it is not a tumor, so we lack that. No focal neurological deficit. Very important. In the patient, we don't find a focal neurological deficit at all. They don't have something to tell me it is a lobar deficit. If I see a patient with raised ICT, the basic problem is this: decreased CSF absorption. What can be the etiology of this disorder? Etiology. One of them, hypervitaminosis A. Number 2, expired tetracycline. Number 3, oral contraceptive pill use. Number 4 is steroid withdrawal. There is actually an abrupt withdrawal that can cause this problem. But the most common cause is idiopathic. The most common cause of pseudotumor cerebri is unknown to us, is idiopathic, unknown cause. That's why the name pseudotumor cerebri somewhere goes missing in my Harrison textbook. He mentions the word as benign, idiopathic, intracranial hypertension. Intracranial hypertension means raised ICT. Benign means without any danger, no focal deficit. Most of the time due to unknown cause, idiopathic. Treatment. You give certain drug that will inhibit the CSF formation, acetazolamide. In the patient has got raised ICT, decreased CSF absorption, not a big problem. I cannot make the CSF getting absorbed so often. I give acetazolamide in the patient. I give a drug which will form less CSF. Carbonic anhydrase inhibitor, acetazolamide. One more thing, you write it down. In the patient of pseudotumor cerebri, there is no hydrocephalus seen. The ventricle size is often normal in the patient. There is no hydrocephalus seen in the patient. The ventricle size is often normal. Chalo, write down one question on this. Interesting question from AIMS. Pseudotumor cerebri is commonly seen in 20 to 40-year-old obese male, 20 to 40-year-old thin female, 20 to 40-year-old obese female, 40 to 60-year-old obese female. What's your answer for this? Simple one, young obese female. It will come as 20 to 40-year-old obese female. Fine. Actually, 40 to 60-year-old female might think that she is young. That's her perception. But for us, it's 20 to 40 that is young. Now, the primary headache types. Tension headache. One easy one-liner on this. Most common primary headache that we know is tension headache. Like I mentioned in the beginning, migraine and cluster headache are also primary problem headaches. Out of the three, the most common is always a tension headache. Most common primary headache is tension headache. The type of headache that the patient typically perceives is a dull aching kind of a pain, which often comes in a band-like sensation on the head. Somewhere like this. Patient might present to you with a face not very happy with tension and a band-like sensation on the head, which is diffuse, which is all constant throughout, dull aching. So the patient feels a dull aching kind of a pain on the head, which is often constricting, same throughout, band-like tension headache. Treatment. If you give the patient, you get a patient who is not having headache very often, episodic, less than 15 days in a month, if the headache is seen, then in that case analgesics are given to the patient. If it is occurring regularly, chronic, more than 15 days in a month, then in that case tricyclic antidepressant TCA like amitriptyline, a very good drug, could be given to the patient. Okay, so most of the time in Harrison nowadays they mention not the word as tension headache, he mentions it as chronic daily headache, daily, on the daily basis, chronic, more than 15 days in a month. So most of the time if the patient comes to me with a daily headache which is of a longer duration, the most common type which we think of is always a tension headache. For dealing with such a patient, you always give amitriptyline. Okay. Second headache, easy and interesting, migraine. Migraine is more often seen in the female than the male population. One thing. In my era, when I was taught this topic, migraine, I was always taught like this: any patient who comes to you with throbbing headache is a migraine patient. No, not a correct statement to be made here, because sometimes a patient with temporal arteritis is also throbbing headache. Just now we listened to that story. Apart from that, a patient who has got an aneurysm, who's pulsating with aneurysm inside his brain, will also have a throbbing headache. So it's not a correct statement that every throbbing headache is migraine. No, 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 no. Sometimes you can underdiagnose, sometimes you can overdiagnose migraine if you think it is throbbing. We've got a very good diagnostic criteria which tells me it is a migraine or not. Diagnostic criteria. The duration of headache very important. Minimum 4 hours up till 72 hours. Some 4 to 72 hours is the duration in which you see the migraine attack very often. Some patients come and tell me, no, they keep on having headache for 2 or 3 days duration. I think it is most likely a migraine patient. 5 or more than 5 attacks in a month, but not a very compulsory formula, but in the older edition of Harrison they mentioned this: 5 or more than 5 attacks in a month, very regular kind of an event. And the quality of headache that we know is PUMA. P stands for pulsatile, that is obviously a throbbing. U stands for unilateral, most of the time on one side. M stands for moderate to severe in intensity. Sometimes patient come and tell me that they are unable to go to work today because of headache. Some people come and tell me they are unable to get out of the bed today due to headache. So the patient is work bound or bed bound. It is moderate to severe in intensity to call it as a migraine attack. It is often aggravation, having an aggravation on a movement. So patient moves his body, moves his head, the pain often increases. Aggravation on movement. So in the PUMA constellation, if I look at, 2 or more than 2 symptoms are sufficient. More than 2 or minimum 2 symptoms need to be there. Either the headache is throbbing or unilateral, I think it is a case of migraine. And sometimes it may not be unilateral, it may not be throbbing, but it is moderate to severe, or it may be even aggravation on movement, that is also migraine. 2 or more than 2 are sufficient. Plus any one of them. Nausea and vomiting, or any one of them. Photophobia and phonophobia. Out of the or and the plus kind of a story which I am telling you, nausea happens to be the most common one. So out of all the symptoms that we know, nausea happens to be the most common finding that we see in the patient. Write a question down on this point. You'll understand this topic well then. A female with episodic recurrent headache in left hemicrania with nausea and paresthesia in the right upper and lower limb. Diagnosis. Option A, migraine. Option B, glossopharyngeal neuralgia. Option C, herpes infection of trigeminal nerve. Option D, brain tumor. A female has come to me with episodic recurrent headache in the left hemicrania and she's having nausea with that with paresthesia. What is the most likely diagnosis? All A correct. This is a chapter of migraine doesn't mean the answer is migraine all the time. Sometimes in examination you get a question like this in which the examiner doesn't give you a full information. He gives you a half information, you just predict it out. For such a question you should have an eye. We should use a theorem that is known as rule out theorem, in which you rule out a disorder, you rule out a disorder, you rule out a disorder, and then you come at a most possible diagnosis. Let's look at them. Brain tumor first. If at all, why brain tumor not? Why not a brain tumor? Because in brain tumor, we get a female who is having a headache, yes, but she will have without any nausea directly vomiting, projectile vomiting, a tumor. And on top of it, she'll have a focal neurological deficit that is lacking in the patient. Or a rule out theorem, Baba. It is not made by me. It is common sense. Rule out theorem. Rule it out, rule it out, rule it out, and rule it in. Okay. Herpes infection of trigeminal nerve. If you remember, herpes virus sits in the trigeminal tract in the Genserian ganglion. It will always cause a trigeminal neuralgia. It will not often cause this kind of an headache. Glossopharyngeal nerve, I remember, is a sensory supply of the pharynx. It will cause throat pain rather than headache. Out of all, I remember migraine as the best possible answer, because she's a female who is having episodic unilateral headache and she's having nausea along with that. Someone had asked me that day, why paresthesia, sir? Good answer. Good paresthesia, why? Sensory aura. It could be aura which could the patient be feeling. Okay, so sometimes premonition aura kind of a story occurs in a patient of migraine, which can be sensory in form of tingling, numbness, paresthesia. Okay, so I believe the best answer which we get is migraine. Now the next step is, how do we classify migraine? We very well classify migraine on a principle that I already mentioned, premonition or aura. Aura could be anything. Aura could be visual aura. Aura could have been a sensory aura. Aura could have been a visual aura. Aura could have been a sensory aura. Someone showing a blind spot in his eye field, that is a visual aura. Sometimes they got tingling, numbness, that is a sensory aura. Out of the two, visual aura happens to be the most common one. Okay. Aura, if at all, is there in the patient, this kind of a migraine is known as a classical migraine. If you don't see the aura, it is known as a common migraine. Why so? Because the common to classical ratio is 5:1. The word common came into the story because it was very commonly seen without an aura, migraine. So it is known as common migraine. Otherwise it is known as a classical migraine. So we divide the migraine on aura, most common visual aura, and if the migraine has preceded by aura, that is classical, otherwise it is common. One more migraine that you need to know about is this, ophthalmoplegic migraine. The word ophthalmoplegia means eye muscle weakness. Migraine, you already know what is migraine now. So we have a patient who has got a migraine. On the side of migraine, he has got an eyeball getting weak. If you remember from ophthalmology and basic anatomy, that the eyeball moves with reference to three cranial nerves, third, fourth and sixth, SO4, LR6 and rest of the third. First, the definition, very important. Ophthalmoplegic migraine is remembered as a partial, recoverable, third cranial palsy. The word is partial because third cranial nerve has got many things to do. It is important for keeping the shutter open, eyelid open. If you have got a third cranial palsy, you will have a ptosis. Third cranial nerve is also important for moving the eyeball except for SO4 and LR6. And third cranial nerve has one more important function to perform, dilatation and constriction of the pupil. The word is partial. For one sense, it is only ptosis. It is no ophthalmoplegia, no eyeball muscle weakness, only ptosis. That is partial, not complete. Within 1 month time it will recover, recoverable. Third cranial nerve palsy. See, unilateral migraine, wherever the migraine headache occurs, on the same side the patient has got ptosis, that is known as ophthalmoplegic migraine. Remember one more important thing, fourth and the sixth cranial nerves are not in the routine definition. Again a reference from one of the newer guides, Rome's and Across and all those guides. They mentioned that third, fourth and sixth are the definition for ophthalmoplegic migraine. No, I've cross-checked it everywhere in all the neurology book, it only mentions third, not the fourth and the sixth. So it is only the third, partial or recoverable. Third cranial nerve palsy on the side of migraine. A very simple definition, ophthalmoplegic migraine. Another migraine, simple to remember, basilar migraine. Basilar artery, basilar artery is formed by the union of two vertebral artery. Circular villus, if you go back to the circular villus, short term memory, two vertebral join to form basilar, which bifurcate to form PCA. Posterior cerebral artery is supplying the posterior half of the brain. What is on the posterior half? Cerebellum and occipital lobe. And there is a migraine in the basilar artery. So if there is a basilar artery migraine, that means the basilar artery is throbbing. The headache will be found on the back of the head, that is occipital headache. Along with that, the patient may have ataxia due to cerebellar lesion. Due to occipital lobe problem, patient might have blindness, and then a complete recovery is seen in the patient. So the patient has got an occipital throbbing headache, followed by ataxia, followed by blindness, and then a complete recovery from everything. That is known as the story of basilar migraine. So we saw a patient of migraine having an artery involvement of basilar artery. In the basilar migraine, very important thing, family history is often very positive. So these patients have got a good family history of migraine, a patient with basilar migraine. Now the thing is theory and treatment of migraine. Two things, theory and treatment of migraine. One theory is serotonergic theory. Serotonergic theory tells me that the 5-HT or the serotonin receptors, which are happily seen on the intra and extracranial vessels, are suddenly blocked. Because of that reason, I get a throbbing kind of a headache in the brain. So why the headache is throbbing? We understand it with the help of a serotonergic theory. So headache is throbbing, one reason, serotonergic receptor blockage, serotonergic theory. Second theory is dopaminergic theory, which tells me that the central dopamine receptors are getting stimulated. As a result, nausea occurs in the patient. Why patient is having nausea? Because the central dopamine receptors are getting stimulated. Dopaminergic theory. Treatment. Simple enough. I'll give a drug which will act on the serotonin receptor and will directly stimulate them. Serotonergic receptor agonist. One of them very famous, the old drug, non-selective drug. Non-selective in one sense, it will act on the intra and extracranial vessel, but unfortunately will act on the coronary and the peripheral vessel. Famous example, ergotamine. Now to get rid of this problem, it was non-selective. No, it can cause ischemic heart disease, it can cause peripheral vascular disease. What to do? We found out receptors which are present on the intra and extracranial vessel. selective receptor agonist, 1B and 1D receptor agonist. A good surname, common surname, triptan, and a very famous triptan, somatriptan. Just to recall this diagram, headache of migraine is like this, comes and goes back. NSAID, that we use painkillers, ibuprofen, paracetamol, diclofenac, anyone, NSAID, only decreases the intensity of headache. It doesn't bring it to zero. For bringing to zero, you need a hero, triptan. So remember this diagram, understand this point given wrongly in one of the pharma guide again. The drug of choice for an acute attack of migraine they mention as NSAID. No. Drug of choice for an acute attack of migraine is always a triptan, not NSAID, my dear friend. Because your guide wala, pharma guide wala has picked up a table from Harrison, mentioning Harrison as mild migraine. There is nothing like mild migraine. It is always moderate to severe in intensity. For such a patient, NSAID will only bring down the intensity slightly. From bringing it to zero, we require a hero, that is a triptan. So triptan have been awarded as acute attack drug of choice for migraine, triptan. Dopaminergic theory. Dopaminergic theory clarifies me that I have to give certain drugs which are dopaminergic antagonist. A very good drug, metoclopramide. Antiemetic, oral injectable, both way, metoclopramide. Now we need to give certain drugs which are prophylaxis agent, drugs which are used for prophylaxis of migraine. We keep on getting a migraine attack patient to our OPD, to our casualty. We are sick of him. Now we need to give him some drug which is at least better at home, can be taken at home and will prevent the relapse of migraine, prophylaxis agent. One of the very famous is beta blocker, and a very prototype beta blocker that is used in this patient is propranolol. Number 2, a tricyclic antidepressant. A good example that I know is amitriptyline. Number 3, anti-epileptic drugs. Nowadays even valproate, everyone is used. Number 4, calcium channel blocker. A very good cerebroselective calcium channel blocker, that is flunarizine. Out of the 4 drugs, the most widely used drug for prophylaxis of migraine nowadays is propranolol. Prophylaxis is often given for a duration of 5 to 6 months. It is not given lifelong. Okay. Chalo, write down one question on this. Actually, 2 questions on this. Drugs used in prophylaxis of migraine is all except option A, somatriptan, valproate, serotonergic drug, tricyclic antidepressant. Which of the following drug is not used in prophylaxis of migraine? My valproate is used, tricyclic antidepressants are used, yes. My dear friend, why not serotonergic drug as an answer? Any ideas for this? Because sumatriptan is a serotonergic drug. Why not serotonergic drug, option C? Why? Any ideas? Because one of the Shimla Center has answered as C, serotonergic drug. Why not C? Why A? I'll tell you one thing. Wait. Sumatriptan is used for acute attack, correct? But sumatriptan is a serotonergic drug. One of the no, wait. I'll give you an explanation for this. One of the serotonergic drug that is used for prophylaxis of migraine is methotrexate. Okay, I'm not mentioning in the routine protocol because not a very safe drug. So methotrexate is one of the serotonergic drug that is used for prophylaxis of migraine. Okay, so don't answer it as serotonergic drug anytime. Answer it as sumatriptan. Sumatriptan is used for acute attack, never ever for prophylaxis. Okay, so that's a good answer for that one. Most widely used anti-epileptic for treatment of migraine, valproate. Valproic acid, most widely used nowadays. Write down one more question. A 60-year-old male presents with headache. Okay. He is a retired army officer with good health, physically quite active, and with no addiction. He complains that his headache is bitemporal throbbing, and worsens on lying flat. He feels better on sitting upright with headache. He has got feverish feeling with decreased appetite. Diagnosis: option A, migraine. Option B, chronic tension type headache. Temporal arthritis. Fibromyalgia. 60-year-old male, retired army officer, physically quite active, no addiction, good health, right temporal throbbing headaches, worsens on lying flat, feels better on sitting upright, decreased appetite, feverish feeling. Good answer. Answer C, I, Aurangabad. Answer A, migraine. Someone has answered B. Oh God. देखो, let's see the question again. 60-year-old male, army retirement person. A person retired from army, I believe, is not very happy with life because in army lifestyle they are more disciplined, and in the civilian lifestyle, people around them are highly undisciplined. So they feel annoyed. They're not happy with life. Now the statement is that he is physically quite active. In spite of his age factor is not something heavy on him, and he is physically quite active, and he has got no addiction. Very important. A person who is alone at home even after retirement, not happy with life, will fall into a trap of addiction. but this patient hasn't fallen into addiction. Possibly he's not having any tension as for now. He complains of bitemporal throbbing headache that worsens on lying flat and feels better on sitting upright. Scalp tenderness kind of a story which the examiner puts you through. And he has got something feverish in his body with decreased appetite. Something itis in his body that is cooking up in his body. So most likely we are dealing with a case of temporal arteritis. Now you know why it is an answer, why it should be the answer, why not the other people around. Fibromyalgia is a disorder in which the body ache and pains often occur, and on the body they have got tender points which is not classically mentioned. Fibromyalgia unlikely. Migraine attack is throbbing, but most of the time unilateral, unlikely to be a migraine. Chronic tension type headache is dull aching, band like sensation on the head, not a typical throbbing kind of headache that the patient has. Okay. No, temporal arteritis can be paratemporal also. There is nothing hard and fast rule. Although migraine is unilateral, yes. Okay. Chronic tension headache would have been a diagnosis if the patient was having some tension, some stress factor, and most important, the headache felt on the patient is dull aching, band-like sensation. Okay. So best answer, temporal arteritis. Now last nail in the coffin of headache. Cluster headache. Cluster headache. As an epidemiological parameter, cluster headache is more often seen in the male than the female population. And as the saying goes, all headaches are more often seen in a female than the cluster headache. Okay. Cluster headache is more often seen in the male population. The headache that the patient typically feels is peri and retroorbital pain. Peri and a retroorbital pain that the patient typically feels with. Along with the pain, the duration is very specifically 30 minutes to 2 hours. It lives in for minimum of half an hour up till a duration of 2 hours. And it is often precipitated by consumption of alcohol. The patient drinks, gets an headache, and very interestingly, it usually awakens the patient from sleep. Patient usually gets up with headache, it's a cluster headache. And again I would say, a migraine patient will sleep off with headache. That means a patient of migraine sleeps, the headache stops. But a patient of cluster headache gets up with headache. It awakens the patient from sleep. The headache periorbital retroorbital is seen on one side, not on both sides. It is usually unilateral. Along with the headache that the patient feels, there is autonomic hyperactivity that is seen in the patient. Autonomic parasympathetic, like increase in lacrimation, increase in nasal discharge, rhinorrhea. So lacrimation and rhinorrhea are the two symptoms which can occur in the patient. Autonomic hyperactivity. Treatment for such a patient, simple and easy. Oxygen inhalation. How does it work really? I could not myself understand it from the textbook, which was a highly molecular way of explaining it. But most of the patients, they have done a trial and they found that oxygen inhalation had a benefit for the patient. So treatment of choice, someone asked me for an acute attack of cluster headache, is oxygen inhalation. Sometimes we may give certain drug which is preventing the attack of cluster headache very often, prophylaxis agent, that is verapamil. Verapamil is a drug of choice for prophylaxis of cluster headache. Verapamil is given not for day or two, it is given lifelong. The treatment of choice is oxygen inhalation. It's a male patient who gets up with headache with consumption of alcohol a night before and has got lacrimation and rhinorrhea, and the headache is on one side unilateral for a duration of 30 minutes to 2 hours. The word cluster came into the story because these patients used to have headache for 1 to 8 weeks in a year. After 1 year, again headache happened. So for 1 year they were asymptomatic. So we found that these patients had attacks in clusters. That's why the name was given as cluster headache. Okay. Okay, fine. Any doubts on headache topic? No, no, no. Uh, Earlier it was prednisolone for cluster headache prophylaxis, the old Harrison. He mentions prednisolone, lithium. No. If you read 18th edition, he clearly mentions verapamil is drug of choice. No more this. Drug of choice or migraine in ischemic heart disease. I'll mark it as triptan. Triptan selective. I think so. The question was different. Drug of choice for migraine in pregnancy. That was a question that I faced once in pharma. They give only give a painkiller paracetamol, although not very effective, but at least triptans and all these drugs are not very safe in pregnancy. So in pregnancy, if someone has acute attack of migraine, I'll just give a painkiller, paracetamol, safe in pregnancy at least. Family history of tension headache. No, basilar migraine was one which was having a family history, not in favor of tension headache. Can we get seizures with migraine? See, sometimes migraine can be an aura for a seizure. I've seen patients who come with throbbing headache similar to migraine and then they have a seizure. So it can not a very good disease that could label it out. Like seizure with migraine, some disorder. No, not very often. Thunderclap is the worst headache of life. First severe headache that the patient tells me. What happened? We had a patient who had a aneurysm. The aneurysm ruptured. It brought around 100 ml of blood somewhere here. Wherever the rupture of aneurysm occurred, patient felt as if a thunderbolt has fallen onto his head. Now this blood in the subarachnoid space could not stand at one point. It moved down with the CSF, as the CSF moves down up and down 5 times in a day. So wherever the aneurysm rupture occurs, it ruptures and puts a headache here, as if a thunderbolt has fallen to his head. And as the blood moves down with the CSF pathway, he feels that the column of that thunderbolt has gone down, earthing has happened. So the worst headache of life, or a diagram somewhere like this, the patient complains. The intensity is maximum at the onset and it dies down sharply. That is the meaning of that word thunderclap, as if a thunderbolt has fallen onto his head and the whole electric current has passed down in his body. Thunderclap headache. Global aphasia is a simple term. Repetition, comprehension, naming, fluency, all four are disturbed. Okay. Thunderclap headache will be a presentation in aneurysmal SAH, not in migraine. Chronic cerebrovascular insufficiency, Belgaum Center. Chronic Belgaum spelling. Belgaum Center, they've changed your spelling here. Chronic cerebrovascular insufficiency means that the patient is having an infarct in the brain. That means the vessel in the brain are unable to supply blood perfectly. As a result, there is infarct in the brain and there is dementia. That was talking about vascular dementia, no? Same story. Chronic cerebrovascular insufficiency, in which you will see multiple infarct in the brain. Okay, vascular dementia, another story. This multi-infarct dementia. Transcortical aphasia, I've already mentioned, means an aphasia in which the repetition is preserved. Okay. Wait a minute, yaar. Oh, where to localize? See, ergotamine, I agree with you, is a vasoconstrictor, but it's a cerebral vasodilator with a vasoconstrictor phenomena again. See, in migraine, initially there is vasoconstriction and there is vasodilatation. Vasodilatation brings you a headache. So, if you give a drug which is vasoconstrictor, it will decrease the headache at least. Okay. Minimum length for giant cell arthritis told by ma'am one. No, it is 3 centimeter. Go and read Harrison once about it. Read the chapter of giant cell arthritis, clearly given as a line. For a high yield for giant cell arthritis, temporal lateral biopsy should be of 3 to 5 centimeter. Minimum 3 centimeter, not 1. See, normal CSF pressure is 150 to 180. Okay. Upper limit is 150 to 180 somewhere. It is somewhere between 150 to 200. It is high normal. That's why the name was not very given written as high normal. It was written as normal pressure. Mysore Center, I am locating your question. Republic. Early and late onset is just the onset, time of onset. Someone has got dementia at an age of 60 plus, late onset. Someone has got a dementia at an age of 20, 21, that is early onset. It is just the age, early and late onsets kind of a story. Array, Lucknow Center, I've already answered this one. Drug of choice for acute pregnancy in migraine is paracetamol. I've checked it again. You don't give ergotamine, you don't use triptan so very often. They are not very safe in pregnancy. You give only a painkiller. No, not often pupillary fibers are affected. You see ptosis, ophthalmoplegia, not very often pupillary fibers. Okay. Aurangabad Center, clopidogrel used in ischemic stroke? No. No. Clopidogrel, if you read Harrison clearly, he mentions that clopidogrel trials were done and not been found to be very successful a drug. Only aspirin is sufficient. Mumbai Center is answering your question. Alwani Center, is the class over? Yes, yes, class is over. Happy? Okay. Because rest of the things we will have it day after tomorrow in the next class. Okay. Any question left here? Crossed aphasia. Someone had asked me this interesting. Crossed aphasia. Look at this. There is a right hemisphere and there is a left hemisphere. Left hemispherical lesion will cause aphasia. Okay. We understand because it's a dominant lobe. But in a patient, a right hemispherical lesion was having aphasia. A patient was having a left hemiparesis. Okay. But the aphasia was to be seen in a left hemispherical lesion. No, this time the patient had got left hemiparesis and aphasia. Usually a patient with right hemiparesis has got aphasia. Why? Because the left hemisphere of the brain is involved. Simple. But this time the patient has got left hemispherical, this patient has got left hemiparesis and a right hemispherical lesion, that is known as crossed aphasia. Because in the patient, I believe, see it's written in the book clearly, in a righty or a lefty, majority of the times it is left hemisphere which is dominant, but sometimes right hemisphere can also get to be dominant, like in a lefty patient very often. So left hemiparesis with a right hemispherical lesion having aphasia is known as crossed aphasia. Hyperacusis is a feature of migraine. It's an aura. Not a very routine clinical feature of migraine. It can be an aura, hyperacusis. See, actually the patient has got phonophobia, no? When the patient hears a sound, he falls, it's all bursting into his ear. So you can put phonophobia in with reference to that hyperacusis again. Hemiplegic migraine, familial hemiplegic migraine. This was something that was seen in the patient who had a family history of migraine with hemiparesis along with it. So there was a study done in some group of patients in which there was a family history, familial hemiplegic migraine. Okay. Dose of lorazepam in status epilepticus. You tell me next time. It's somewhere 0.15 milligram per kg. I'm not very sure. You can check it yourself also once. Spike and dome pattern on ECG? EG. Migraine most of the time is unilateral. Spike and dome pattern is seen in absences. I mentioned in the earlier class, it's in the beginning phase. Spike and wave slightly looks like a spike and dome also. Okay. Okay, thanks a lot. We'll see you next time. Next class we'll start with that spinal cord chapter. Most common seizure seen in children is subtle seizure. Subtle, minor seizure. One liner question. Gate NVNT and I don't understand the question. Aurangabad Center, what are you asking? Gate problem is slightly late, somewhere midway, later. You don't see the gate getting abnormal at the day one. You see it later in the disease. Cognition in English means understanding. Cognition means understanding what is going around. Comprehension. Someone is talking to you, understand, that is cognition. That is comprehension. So the word cognition means to understand what is going around. Okay, fine. Sure. It shows the slides of Alzheimer's. Some people have missed it actually.